Good morning, everybody, and welcome to this meeting held in public of the Royal Cornwall Hospitals. Can I just welcome everybody in the room here in a rather damp and windy Truro, and welcome everyone who's joined us online. A couple of bits of housekeeping to do before we start. I could just remind everybody that we live stream these meetings, and we will place a recording of the meeting on the Trust's YouTube channel. And could I remind members of the public who are watching that Teams Live has a feature of live subtitles, and you can access them by clicking on the screen. And just a few other bits of housekeeping and etiquette. First of all, can I just say, colleagues, we've got an awful lot to get through this morning by 1 o'clock. And so it would help me to get through it in time if we could all keep strategic, and if our executive colleagues could keep their introductions as short as possible, consistent with good governance. Hopefully that'll mean that we won't be chasing time at the end of the meeting and everyone gets a fair crack at the whip. In terms of fire alarms, we don't have any drills today. I think we're in a different building than usual, but I don't think we have any drills.
No, we don't have any drills today, no.
And the facilities are just outside the room in the corridor for those who need them. We will have a break after a couple of hours, but if anyone does need to get up and move around, that's absolutely fine if you need to. And if there is a fire alarm, obviously we've got appropriate arrangements in place to evacuate colleagues, but we're asked to vacate the building and gather in the car park outside. And then we do really welcome questions from members of the public, and I hope you can all hear me online. If you do have any questions, please use the question and answer function on Microsoft Teams. And the protocol is that the company secretary will ask the questions on your behalf and an executive director will answer them. Or if we don't have an answer immediately available, we'll write to you afterwards. So we hope to conclude at around 1 o'clock, and that means we'll probably be breaking in about 2 hours' time, if that's okay. In terms of apologies for absence, we've got apologies from Robin Jones, Chief Operating Officer, and he's represented today by Joe Floyd. Welcome, Joe, the Deputy Chief Operating Officer. We've also got apologies from Aled Jones, Ray Hall, and Brian Johnson. At item 5, Bernie George, our Acting Chief Nursing Officer, will lead an item on corridor care, and that will be supported by a video. And then lastly, but not least, could I welcome Stephanie Creek, our new Deputy Company Secretary, who joined us yesterday, I think. Stephanie, so welcome to your first board meeting, which I hope is the first of many. And then if I could move on to item 2, declaration of board member interests relevant to this meeting. Are there any declarations that anyone would like to make? If not, can we keep moving to item 3, the minutes of the previous board meeting held on the 7th of May. Are board members happy that these are a correct record? Thank you very much. And then item 4 is the matters arising and the action log. We don't go through this in detail in view of time. I just ask the company secretary if there's anything she wishes to raise. And are there any issues board members would like to raise on the action log? Okay, thank you very much. So that takes us on then to item 5, the board story. Could I thank on behalf of the whole board, so that everyone doesn't have to thank Bernie for this board story and the accompanying video, and hand over to you, please, Bernie.
Thank you, Chair, and good morning, everybody. I wanted to take a moment to introduce the Trust Board story, which focuses on the experience of our patients in our hospital who've recently endured corridor care. We continue to have a large number of patients placed in designated corridor spaces in line with national guidance in the emergency department and on our wards due to capacity pressures. And it's important for us to reflect on how this has impacted them. Their stories remind us of the real immediate effects our processes have on those we serve and underscore the urgency of our commitment to eradicate corridor care. We must remain resolute in our determination to eradicate corridor care in our hospital. It is not just a policy stance, but a promise to our patients that we are striving for better standards and environments for their care. Later in the board agenda, we'll be discussing this issue in greater detail, exploring both the challenges and our actions. In the interim, I encourage you to consider the experience of our patients who've been on the receiving end of corridor care. Their voices and perspectives provide valuable insights as we continue to work towards meaningful improvement. I'd like to thank the patients that shared their experiences with us.
Coming in initially, we're in the corridor, been there for quite a few hours. To have any medical work done, we're then taken down to minor injuries to another room to get some privacy because there wasn't any, and then brought back here again and put into the corridor again, and eventually we've now got a room, but we haven't got an actual proper bed yet. So yeah, we've been here. What time did you come in? 4:45 this morning. So a long time just to be out there, and there's a lot going on and buzzing around. So, but the staff have been brilliant. It's just the fact, accommodation.
I don't know. We've just been sat here for a couple of hours.
Yeah.
Yeah, we've seen nurses and doctors. Yeah, and a tea trolley. It's not affecting me at all. I'm sat in a chair next to my wife. My wife says it's okay. I mean, it's not much different to being here than sat in one of those two wards, people walking past anyway, so
it's actually for my daughter, but yeah, she's we've been looked after while we've been sat here. We've had tea, coffee, they've provided snacks for her. It's been okay as far as I'm concerned. At the end of the day, there's not enough rooms, and there's not enough beds, so at least she's being treated. That's the main thing.
Absolutely fantastic, to be fair. I got brought in by ambulance and I've been looked after fantastically. I can't ask for better. If that's the only way to get it done quickly, what's the problem with that? I wanted to get treated as soon as. So, yeah, that's it.
Having been moved in and out of the ambulance 3 times, into the ADL, a random room, rats twice, then into a corridor, it was crazy and no one really knew why we were anywhere until we ended up in the corridor. I appreciate it's incredibly busy, but it was truly dreadful and incredibly stressful, especially for someone with ASD, sensory needs and poor mental health. My girl wanted to leave. There was no understanding or support for me trying to deal with my girl going into autistic meltdown. Oh, and I was appalled.
I really do appreciate the pressure on the beds. However, the permanent use of trolling corridors, in particular, allotting place outside frequently used toilets, is disgraceful. I'm well aware of the pressures on staff and how stressful it is. However, when face-to-face with patients, it should be imperative not to make the patient feel like they're an inconvenience and increase their distress, which was how I was made to feel on several occasions.
My father was left for hours on a bed in a corridor, cold and hungry. Have the decency to at least notify people what is going on. I'm shocked at what my father has told me.
I've been here in the corridor for hours. We're packed in like sardines, so it's very uncomfortable. But I am receiving good care. It's much better than I expected, but it must be really difficult for patients who are here alone.
All staff were very kind, but it all seemed so chaotic. I was sat in a wheelchair in a corridor for 8 hours.
I'm very upset with being treated in the corridor. I'm diabetic and I've missed my medication. I've been completely ignored.
I was in an ambulance for 9 hours as there were no beds available. When I finally did get a bed, it was in a corridor and I was kept in overnight.
Nothing more to say. 6 hours wait, but ambulance queuing outside. Everyone doing their best, but communication became limited to patients. More blankets needed for patients in corridors or squashed into a side ward like me.
Bernie, can I just check? I think there may have been a problem with the sound for people online.
So our colleagues who are online couldn't hear it, but everybody else in the public could.
What do you say, our colleagues? You mean board members?
Board members, yeah. I fixed it for them now, so it should be fine. Sorry, Dave.
So, can I apologise to board members who joined us online? You may already have viewed the video with the link that was previously sent, but obviously we'll make sure that you're able to watch it. Bernie, is there anything you'd like to add?
Just that we're sorry. It's a hard hear. Even for those that have positive experience, it's a hard hear, and it just, I think, strengthens our resolve that we must eradicate corridor care.
I'm sure we'd all endorse that. First of all, Adrian, and then Ella.
Yeah, thank you very much for that, Bernie. It tugs at the heartstrings. I wondered if we ever get feedback from staff on corridor care, because I think that has an impact on staff as well. And I'd be very interested to see what their thoughts were.
So I look to Mary too, both in our emergency department and in our ward areas, staff find it really challenging to care for staff, for patients and their families in a way that they would not want to do. So that kind of moral injury piece is really important. And recently, particularly in the emergency department, we've looked to provide some additional support to the team around that when we had that real pressured point a couple of weeks ago. They spoke to Mary, Robin and myself, and we were able to put some additional support in, but it equally impacts on our staff as it does on patients, because that is not how they want to care for people.
Okay, I'm going to come to Ella. I'm afraid I can't see on my computer who's on screen at the moment, so I'm going to have to look over Kim's shoulder. Who's on screen?
Richard is on screen and Ella's got her hand up.
Thank you. It was hard to hear some of those experiences. It was also, I think, good to hear in some cases where, despite the limitations, people felt they were treated with dignity and respect. And obviously, we'd expect that all the time for everybody. I just wondered on the areas where we heard they weren't, where people felt, for example, they were an inconvenience or the communication wasn't good. What reassurance we have that the teams are doing that continuous improvement approach and reflecting on the experience, whilst we can't, at the moment get over the fact people have to be in corridors, we can reflect on how we treat them when they are in the corridor.
So the team pick up on that feedback, they use it through their governance routes, they pick it up through their safety huddles as mechanisms to make sure that those small things that people are talking about in terms of their experience are worked through. We've also made some changes around some of the skill mix, particularly in the emergency department, around the role of the nurse in charge. So yes, that feedback is heard, and they use that to manage on a day-to-day basis.
So I'm Richard Kramer. Ned, I'm really glad we had the conversation. It's good that we don't shy away from these difficult topics. However difficult it is for us, it's just awful for patients and staff, particularly disturbing to hear about the patient with autism and having to experience sensory overload in a very tight corridor care is very disturbing. I just wanted to get a sense of the number of patients exposed to corridor care each month and some of the trends in terms of the length of stay.
So we now capture that through radar, Richard, and we can now start to produce a monthly well, we can look at it in day about how many patients are in the corridor. I haven't looked this morning, so I can't tell exactly how many patients are in corridor care spaces at this point in time. But they will vary. in terms of day and night. And in terms of hours, we can also track that too. The ward teams currently do a review at lunchtime, and we are exception reporting any patient that stays longer than 12 hours in a corridor care space. But in terms of the data over the last week, I haven't got that to hand, but I can get that for you and I can circulate that around.
Okay. I'm back online now, fortunately, so I can see hands going up. The only thing I was going to suggest is, could we keep our comments on the video? Because otherwise we'll stray into the later conversation about corridor care, just to avoid duplication. So if I take two more comments, one from Adam and one from Isabel Down, both non-executive directors. Adam?
Thank you, David. My question wasn't on the video, but I'll just say, so I'll save that for later, but I'll just say thank you for the video. Thank you to the people that took the trouble to give us the feedback. It's really important that we hear that and do something about it. So it's great that we're having the conversation. I'm sorry that we're in the situation we are.
So, Isabel?
Sorry, David, I didn't hear you. Yes, I missed a lot of the video, sadly, because of there was a breakdown in the connection. But I just wanted to check that in the video, did we feature our volunteers at all in terms of supporting those patients on corridors? And are we looking at enhanced input from our volunteer workforce?
So we have dedicated volunteers in our emergency department, and they support patients in corridor care. There was no volunteer videoed in that video presentation, but I can absolutely confirm that our volunteers are in the emergency department and they do provide that additional pastoral comfort and support to those patients.
Thank you, Bernie.
Thank you very much for that video, Bernie. And I think we're all very sorry for the situation that we're in. It is a complex system-wide issue, indeed a nationwide issue. But nevertheless, we should say that we're sorry for patients and their families who are in this situation. And clearly what we've done so far is not enough to resolve the issue. So we have to think differently, which we will be doing later in the meeting. So thank you very much for that, and that will inform the later discussion. So if we could go on to item 6, my report. I'm going to try and set an example and not say anything. So I hope it speaks for itself. But I'm very happy to answer any questions, of course. The only thing I need to say to you is that we have been selected to be in cohort 1 of the NHS Board Development Programme, along with our partner trust, Cornwall Partnership, NHS Foundation Trust, and with our commissioner, the Devon and Cornwall, or Cornwall and Devon Integrated Care Board. So we need to endorse our participation in that if the board is happy. And it does involve you committing to a whole board development session within the programme timeframe, which will be an extra commitment, but hopefully will be a good investment with I think it's KPMG, isn't it? Deloitte, sorry, with Deloitte who are partnering to do it, and delegate authority to me and Kim, the Chief Executive, to finalise arrangements. Board content? And we'll try and do that with system partners to get the value from all of us being in the programme. Are there any questions for me on my report? Okay, let's keep moving then. Item 7 is the Chief Executive's report, Kim.
Thank you. I'll try and be as succinct, but I don't know if I'll be as short as yourself, David. So please, it's a comprehensive report. I'd like to just reinforce that UEC, women in urgent and emergency care, women and children are on the agenda today, so I won't be going through those to avoid duplication. And e-care, a very brief statement on there as we progress, and we've got an agenda item at private board, so I'll keep it at that. It's really important to know, as a Chief Exec, I am continuing with my commitment to meet staff across our organisations. This is not tokenistic, and I hope you can see from the report that actually going out and talking, I'm also providing feedback, personalised thank you cards, and also making sure that where they've raised concerns, we are taking action. You can see that we've said, you said, we did, and some of that will come up through the staff survey action plan. I really want to take note that Bernie and myself attended the annual Healthcare Support Worker Conference on the 16th of June, and I've just written "The future is bright." It was a vibrant community across Royal Cornwall Hospital and Cornwall Foundation Trust. 6 of our healthcare support workers shared their journey across all services, and I would really like, and I've spoken to Bernie and Pete, who was there, to bring back a story of some of the highlights of those journeys. It was inspiring. So it's just to note that. NHS Confed was held. There was over 12,000 NHS delegates over 2 days. Alison and myself were there with some of our teams, and we can already see where we've been, and we went everywhere. Really great to see culture was there, and the word kindness was really, really reinforced, and that's part of our cultural work that we continue. SASH, our St Austell Surgical Hub, has now been accredited, and a huge congratulations to the team, a really outstanding recognition. Maternity, it was with great sadness and distress that we received both the Donna Ockenden Nottingham Maternity Review and Baroness Amos independent investigation into maternity and neonatal services over the last few days. And our thoughts go to our colleagues as well as the families that have been affected. We've had quite a tight turnaround as regards a board assurance statement, which is due on the 31st of July, and that's linked to the Fuller inquiry. And we know that that was dignity and death, which is featured in the reports. And we need to do an assurance statement signed off and acknowledged by the board, as I've said, by the 31st, and I'll come back to Lindsay on how we're going to do that. David, Lindsay and I have discussed, because we don't have a board before the 31st of July. We have to note that there are many actions, thoughts and considerations within these reports, and our maternity team, alongside Bernie as Chief Nursing Officer and Mary as Chief Medical Officer, is working collectively with the team, and we know we've got an integrated maternity improvement plan, and that will continue. And we are also supporting our teams through this, noting the distress it's caused families as well as our colleagues. I think, well, I'll only bring attention to the Lord Mansell review, and that again, we've got to do a board assurance statement for the 31st of the 7th, anti-Semitism and the government definition of anti-Muslim hostility, and that's the Lord Mann report, which we'll come to as well, noting it's the second one that we've got to give assurance for before the 31st of July, and that there's a Band 5 national job evaluation that we have to submit for our nursing teams by the 31st of July. And then just to note that the governance improvement plan that we've all agreed is in my report as well. So on the note of the 2 assurance statements, Lindsay, I don't know if you'd like to suggest the way forward.
Yes, so as we have only received these recently, Chair, we are really keen that we ensure that we have the opportunity as a board to consider that. So therefore, we will take both the Lord Mann recommendation and the Fuller Inquiry Board Assurance Statement through our relevant committees. So that'll be Quality Assurance Committee and People and Culture Committee at the end of July. We would like to, with the support from our committee chairs, to invite all board colleagues to attend those items so they can ensure that they are observant and have the opportunity to comment. And then if it's acceptable for the chair, we will ask that we recommend to the board approval through e-governance on this occasion. purely because we are unable to meet again until our board meeting in August.
I'm not sure whether e-governance would be appropriate, certainly for the MAN report, maybe for the Band 5 job evaluation. I don't know if there is an option to consider it at the board on the 6th of August.
So the deadline is the 31st of July. So we could inquire as to whether or not there is a delay, but that's obviously a national requirement. So I'm unsure whether we would be supportive of that.
So if we're not ready to approve it today, I think we probably have to have a special board meeting. What do board members think? So I'm going to suggest that we do have a special board meeting to consider at least the Lord Mayor recommendations, because it is a matter that should be signed off by the whole board. I think. Not quite sure why it's not in front of us today, but let's make sure we approve it by the end of July.
Yeah. Take action to canvass a date and get something in the diary check.
As far as the Band 5 job evaluation is concerned, which obviously is important, but perhaps doesn't require as much board level that can either be delegated or it could be considered at the special board meeting.
Therefore, I would suggest it's the Lord Mayor and the Fuller inquiry response.
Board content with that? We do have a non-executive maternity champion, Dr. Rebecca Hopkins. Entirely up to you, Becky, but I don't know if you wanted to say anything about maternity.
Thank you, Chair. I think it's, I sort of echo Kim's comments about the national reports and that maternity safety is hugely important, both to the Trust and wider as well. I think we'd really like to kind of acknowledge that and the Jim Mackey's 10-point plan, which has just come out in addition, specifically around health inequalities, which we can come to later. But it's incredibly important that we listen and continue to listen to women and their families on their concerns and the experiences that they have, and also to support our staff. So patient safety is of the utmost importance, and all we can do to help and to improve that, the better. Yes.
Thank you. I think for members of the public, it's important that we have a GP on the board, but who's also as a non-executive representing the public voice in relation to maternity services. Anything else from you, Kim?
No, finished from me. Thank you.
Okay. Are there any questions or comments for Kim? Richard Kramer.
I just want to say something about the Lord Mayor report, because it is really important that we respond to this. It's not a policy or training issue or even an EDI issue. It's about making sure people feel RCHT is a safe, fair and inclusive place to work. Alison, as dual people officer, and I've talked about inviting our networks to a future meeting to hear from the lived experience of those affected by racism. And I think it would be useful for the board to have a session with people so they can hear directly about their experience, just to connect those threads together.
Thank you, Richard. Ian Dean, Chief Finance Officer.
Thank you, Kim, for your report. So conscious in board in private, we've got more papers on our women's and children's update, just helpful for, I think, members of the public and our staff to know that the stocktake meeting referenced in the report was really successful event. That was National NH New Hospitals Programme team, along with our regional team and our Integrated Care Board, coming together to assess the current position of our scheme. It was really strongly supported from all parties, and we are making good progress and being encouraged to get that momentum and to make progress through the new Hospital 2.0 framework lines. So we'll bring more updates to public board so that members of the public and staff can understand the key milestones on that journey over the coming months and years, which will be a massive, exciting development for patients and their families in Cornwall.
Thank you. Could I just add to that, if members of the public or staff are concerned about the transfer of capital to the Defence Investment Programme. The Prime Minister's spokesperson has not made any commitments to waves 2 and 3 of the programme, but he did commit to wave 1. So as far as we're aware, the funding for wave 1 will not be affected by the transfer of capital resources to the Defence Investment Programme. Uzma Bozai, Non-Executive Director.
Thank you, David. Thanks for your report, Kim. It was great to hear about the innovations like the Pocket Talk in your report. I was just wondering whether there's any plans to roll that out to other areas of the hospital.
So we do have the language line as well, Uzma, so I'll pick it up with Bernie as regards following the success in maternity, whether there's a more blended approach with both systems. Thank you.
Thank you.
Uzma. John Foster, next director.
Thank you, David, and thank you, Kim. Similar theme to Uzma's question. Zooming out a little bit first, it was really good to hear the personal approach we're taking around Ockenden and Amos landing both for staff and patients. I think that's so important with such complex, emotive and difficult subjects. So it was really good to hear that in your update, Kim. On Pocket Talk specifically, I just wanted to ask a couple of questions on that, because I recognise it's such an important improvement and really will do a huge amount in supporting those patients we have that don't have English as a first language. I just wanted to confirm that that wouldn't ever be used in place of a in-person interpreter when available. So I recognise that that will be a really important first-line tool, but we'd always look to in-person where it's appropriate and needed in clinicals. So just wanted to check that. And also just wanted to ask if we had any milestone plans in place to look at reviewing the effectiveness of that system so we can be sure that it's doing what we feel we want it to and build in any learning, particularly with a view to potentially rolling it out elsewhere if we do go down that route, as Uzma asked. So.
Thank you, John. So it's really important that often we have struggled to get a translator in person. There's so many different, we've got such a diverse community now and it's growing. So this is an absolute an aid to be able to provide that. It has 90 languages, as it says. So yes, we'd always, where we can, we've absolutely had to move away and reinforce that we can't use a relative voice, for example, and that's making sure that the patient's being advocated for correctly, which is really, really important, and that cultural aspect and inclusivity. Yes, we will have a look at reviewing, and I'll work with Bernie and the team to make sure, because that will help to make sure we've got the right efficacy of it, that it's working well, especially for our patients, and also what does that rollout look like, but complementary to our other system. But it's been really warmly received, especially when after hours, when really getting hold of other people can be tremendously difficult in a rural community.
Thank you.
Thank you.
Thank you, John. So if there are no other comments or questions for Kim, can I thank you for your report, Kim, and move on to section A, which is matters for discussion and decision. And the first one, appropriately, is item 8, urgent and emergency care. We've all read the paper, but Jo, is there anything you wanted to say by way of introduction?
It was just to note really that as everybody's read the paper, the Trust does remain under significant operational pressure and did during June. We have seen some slight improvement at the end of June. We're not meeting our trajectories, but we have reduced the ambulance handovers by 12 minutes to date. And we have seen, as we were talking about corridor care spaces, where we were averaging 17, we're now down to 13 average spaces a day. So we are seeing some of the metrics improving. During May, just to note, we did have the 2 May bank holidays, and we did have that amber heat warning, which put significant pressure on the whole system, with SWAS seeing one of their busiest days since post-COVID. Also, I think that one of the main factors of the poor performance during and the deteriorating performance in May was workforce pressures, both with whilst improving, and we've got ongoing interviews and recruitment happening. We have got some key clinical and operational vacancies at the moment that has still been impacting, along with some staff absence that was higher in May than we would have had before. We've put in a suite of additional actions, recovery actions. Those have been presented to Isabel by Robin, with further actions still being worked up at the moment. So the key actions that we've put in place is the relaunch of the GERFT clinical operational standards, with a very strong medical leadership focus on that, and that is improving. Consultant engagement programme and clinical leadership workshops are being organised. Daily ward and specialty capacity and demand reviews. So we are absolutely getting down into the micromanagement of those patient journeys and reviews, and to make sure that every action is being done to improve that flow. The bed capacity and modelling, that's an ongoing piece of work, but we are undertaking that with our business information team to make sure that we have got the right bed modelling and capacity that we need, and reviewing that along with the increased acuity that we've seen year on year. The increased learning from corridor care, which we've touched upon, and the root cause reviews that we're undertaking to make sure that we're capturing that learning, and of course the debriefs from the Amber Heat incident that we had. We've already completed that debrief, and we've got put the actions into place, ready for possibly next week. Recruitment, as we said, to the new acute medical clinical lead, and we are reviewing and strengthening our escalation arrangements and our cards. Yes, the board is asked to note the additional assessment being completed by the acting chief executive and chief operating officer in response to the performance not improving, and that will be finalised and shared to the vice chair on the 30th of June. Note the target to have the updated modelling of the impact and existing improvement initiatives, and an assessment of bed capacity will be shared with the vice chair on the 30th of June as well. Note the significant operational pressures experienced during May, including the deterioration in urgent emergency and care performance when compared with April 2026, and the increased emphasis on daily ward, specialty level capacity and demand reviews to support the delivery of getting it right first time, the clinical operational standards.
Thank you, Jo. Isabel, can I check, was the assessment shared with you on the 30th of June?
Thank you. Thank you, Chair. Yes, it was. I had an hour with Robin on the 30th, and Robin has put together a set of slides which we worked through together during that meeting, which was immensely helpful. I think underlining the things that Jo's just shared with you this morning, but I think also importantly to recognise that despite all the actions and the suite of actions which will come via the Quality Committee and the Finance and Performance Committee for scrutiny, I think there is an acceptance that we need to probably have some strategic rethinking about some of the work that we're prioritising at the moment. So I think that's going to happen, and I know that there's going to be a discussion coming back when Robin's back from being away today. But it was very helpful, and certainly I can't fault the amount of work that's going on by Robin and the entire team, actually, and Mary with her medical colleagues to try to get some breakthrough on this. But we still, of course, have the same problem of how we get patients who are ready to go home out of the hospital and freeing up the beds that we need.
So, anything to add from your point of view, Kim?
I think we have to recognise, and seeing the board story today, we haven't made the strides we wanted to make to eradicate corridor care, and part of the work that Robin and Jo and Bernie and Mary are doing is re-looking. It isn't that everyone isn't working hard, but that as hard as they're working, we're not getting the outputs we require. Mary might want to talk a little bit about the senior leadership team led by Toby, who is one of our associate medical directors looking at urgent and emergency care, had an away day. to look at flow and to look at how we can do things differently. And they had a really productive day alongside the actions that Robin has shared with Isabel, which is a joint piece of work because, of course, it's clinically led but operationalized. It's really important on how we re-look at some of the flow. It isn't just a front door issue. So we can say that we've had a peak, but actually if you look at it, actually have we used all of the out of hospital alternatives, for example, but we also need a stable throughput. So our discharges need to be fluid and high. So that comes back to us doing our part as an acute trust, but working with partners as we move, and especially when we do the left shift into neighbourhoods, are we absolutely working as a system? And some of that work, as we've said, is being done as a system. Mary, I don't know if you want to talk about the away day.
Yes, so I've scribbled down 3 things as you were talking, Kim. So Toby Slade, one of our A&E consultants, also one of the associate medical directors, is leading a piece of work around the Get It Right First Time, the GIRF clinical operational standards. That's already been alluded to. The key to embedding the clinical operational standards is that it needs to be a multidisciplinary team approach. It can't be any one professional group that is shouldering the burden of making sure that those standards are implemented. And so one of the things that Toby has done, and he did it, I think it was last Friday, was to host an away day, not just for the senior medical leaders, but for the senior nursing leaders within each of the teams, so that they could spend the day developing a new relationship, because obviously the divisional restructure has been relatively recently, to learn to work together in a much more seamless fashion, and then to really look at the clinical operational standards and how between them they could make them much more meaningful to the multidisciplinary team and get that embedded in a way in the way that we need to have it done. And the initial feedback is that was an extremely successful away day, and it is one of a number that are planned over time. Clinical operational standards I've mentioned, and I think we will continue to mention the work that's being done around the clinical operational standards, and GIRF will be coming in to look at what we're doing and to support us in a week in July. But we are making them very real. We are making sure that there's a cascade of that information from the executive team through Toby to the divisional leadership team to the group leaders and down to the services, so that there is a real strength in the core message that is going out around clinical operational standards. And then the third thing, I wrote system as you said it, Kim, and what we have been aware of over the last few months, because of all the inevitable changes that have happened across the system with our ICB, is that some of the forums that were beginning to get to grips with some of the system challenges around our urgent and emergency care forums had fallen away a little bit, and we weren't seeing that level of movement, particularly around the clinical system players. So we have re-implemented a clinical system leadership group who are looking at specific focused patient pathways to see if we can take down the barriers, unblock anything that is causing a lack of pace towards arranging alternative pathways of care, basically, for patients who can receive safe, high quality care out with the hospital. And what we're doing that is we're going pathway by pathway to try and get a bit of speed behind those changes. So there are 3 key things that are happening on the clinical front.
Thank you very much, Mary. Could I just mention that I spent a day earlier this week with 3 of the emergency department consultants and a consultant from Plymouth, interviewing for 3 new emergency department consultants. We were able to make 3 excellent appointments. Alison was there as well. But also it was very helpful to spend the time with the emergency department consultants and understand, the challenges they face and how they're trying to deal with it. We've got a number of people waiting to speak. Could I go to Richard first, please?
Yeah, thank you, Chair. I was listening carefully to what Joe was saying, and you talked about some staff shortages in key areas. You also talked about staff sickness. So I suppose it made me think about some of the staff costs associated with operational pressure. So I suppose I wanted to know, I think in future reports, it'd be very useful to have those workforce trends so that we can understand, as well as the issues around flow, the challenges for patients and our staff, and to have some assurance that we're supporting staff wellbeing and some updates on the recruitment to those key posts. And lastly, the report talks about 12-hour wait. I know we've had 24-hour waits. I just want to know if we're still experiencing 24-hour waits as well.
Yes, during May, we did see a rise in the 24-hour delays as well. We obviously put in the ED safety checklist. We've got that in place for patients that are 12 hours and then 24 hours. We've only had 2 over 48 hours, but they were very complex patients that needed mental health support and adult social care support. So as far as bed flow is concerned, we haven't seen that extreme, but it has been very challenging. And when we had a period of infection control issues, the 24-hour period as well for the capacity for side rooms as well impacted. We'll certainly pick up the workforce. There is a huge amount on the ground happening for staff wellbeing, because when we do see short notice sickness in particular, we do have to manoeuvre staff around to be able to make sure that we've mitigated safety actions. But there is a lot of work ongoing, and the heads of nursing that are in place are working very hard with the ward leaders. It's the matron post that we are still recruiting to, and they're embedding into those roles, and some of the deputy heads of nursing roles as well as the service manager. So we are getting there, and it is improving, and we've got some great appointments that have come in on place, but it is just recognising that at the moment it's just a little bit tight at the moment for that support. But yes, thank you. I'll pick that up for the next report.
Thanks, Jim.
There are 6 people waiting to speak, including you, Bernie. Did you have your hand up?
I'm going to put it in the chat, my response. I can give you a bit more detail.
I think there were 5 people waiting to speak. Is there anyone else who wants to speak on this other than those who are waiting? Well, if not, shall we take the people who are waiting? Then I'll attempt to summarise at the end. I think we might want to do something a bit stronger than noting, and then move on, if that's okay. So the next one is Becky Hopkins.
Thank you, Chair. Just to say really that general practice, in particular GP Collaborative, but the wider system as well, very supportive of making sure that patients are in the right place at the right time, both minimising or reducing the need for hospital admission, but also for having safe and effective discharge with the right resources around them. And really, the GP Collaborative are very keen on having, at some point, would be love to have the integrated neighbourhood team on the patient's bed or within their record, so that everybody within the hospital system knows which integrated team to communicate with, and more contacts with geriatricians, in particular for frailty, for example, to enable patients to stay at home where possible. I'm 100% supportive of maximising system capacity outside of the hospital, and with that also needs to come social care capacity in addition to support those patients with their social care needs while they're having their medical needs dealt with. I can safely say that acute care at home are working incredibly well and incredibly high capacity already, and it is quite challenging actually. They squeeze patients in a moment's notice for general practice, and do so with a huge amount of humility and dedication. There are opportunities, however, in some of the other services to maximise things further, and I would support further discussions with the clinical pathways that Mary described, both with the GP Collaborative and with the ICB urgent and emergency care commissioning team.
Thank you. Now we go to Adam Broom, Non-Executive Director.
Thank you, Joe. Recognising this is a challenge across all of our sites and all of our services. You mentioned the heat. Could you say a bit more about how we made things as comfortable as we could for patients and people working in emergency care, please?
Of course. So in emergency care and also on the ward basis as well. So air conditioning units where IPAC allows, and we facilitate that. So we've got air conditioning units. We've deployed more fans this year than we have ever before. We actually had a plan and we decanted the neonatal unit, which actually overheated. So we were able to decant that, and we have a good, robust business continuity plan in place for that. We had bottled water for patients and staff, and also ice lollies twice a day where required. We have obviously the heat wave plan, which says about how we draw curtains, how we try and minimise, heat coming in. We've worked really closely with our estates team to make sure that all of those functions that are up and running, and also if we have got high risk patients who are at high risk of heat, we move them to cooler sides of the hospital or even the ward, so that we are absolutely making sure that we are transferring patients in the best way possible. So they still have the right care, but they're in the coolest part of the hospital. So all of those operational actions are being undertaken with the estates team. And we have those site safety meetings during heat. We had the ICC, the Incident Command Centre open, and we were doing 2-hourly meetings to make sure that all of those actions and patients and staff were looked after in the best way possible. I think we had one incident where a staff member was sent home because of the heat, but apart from that, everybody else we managed quite well.
Thank you.
Adam. Yeah.
Yeah, thank you. Thank you for the report and the updates. I talked about it previously, the improvement objectives, and the paper alludes to it on page 51 of our packs. We've got the improvement objectives that we set for the end of May. Obviously, we're behind on all of our trajectories, as we've recognised. And it does talk about a need to reassess that. I think from a board perspective, I'd welcome us looking at that and what can we learn from when we set that previously, and how we go about setting that again, because I think it'd be helpful to understand what that improvement journey looks like and what are the key priorities. Because my reflection on that is there's probably too many things that we're trying to do in that, and which are the vital things that we think, based on the updates we've had about the visit to Chelsea and Westminster by our colleagues in the emergency team, so that we've got greater assurance at board about how that improvement is going to be brought about by all the good work that I know is going on, Joe. So just a reflection really on that table. I think that's become quite outdated, and I'd just welcome probably a review of how that is presented in this report going forward.
Oh, Ian, just to quickly say, the actions that Robin has taken and spoken to Isabel about, there are 6 key actions there. And when it's gone through QAC and FPC, then it will definitely come here so that can be discussed.
Thank you.
Kim is next.
Yeah, I think as a board, we've got to keep that strategic helicopter view. There are only 3 principles that we should, and everything should hang off those. It's urgent and emergency care, it's the transformation of our outpatients, and of course it's that left shift into neighbourhood, and I think everything should hang from there. We've got to keep that really, really clear and focused. As a board, we are all accountable, and that's really what we are here to do, and none of us have stepped away from that. And it's that board curiosity. So how do we learn from the best? So the reason the teams are going to other areas is that curiosity and to learn. And let's not forget, people are coming here to learn from us. So we always need to seek to endeavour, and we might not be able to lift a model straight as it is, but there are principles within that model. Getting it right first time is the vehicle to be able to do that. And we know that we've got a visit in the next 2 weeks, and there is good involvement from the senior leadership teams across the board. As Mary said, this is not one profession. This is how we collectively work together, and our digital agenda is key critical in that. So it's just to keep us up there and making sure we're having the right conversation and curiosity, and to let the operational teams operationalise the clinical model. I agree, I think, and that's why we are reviewing with the teams. There are too many actions, and if we go back to the 3 principles, what is our role as a good partner, and then what is our system role in being able to do that as we're all undergoing change is really important. Thank you, David.
And final comment from John.
Yeah, thank you. So I'd really support what you've just said there, Kim. We had a really good discussion on this at Quality Assurance Committee last week, and I'd agree. It feels like the right time for that strategic review that's been discussed. So really looking forward to that. I was going to ask how we were doing on learning from other trusts, but we've covered the Shell West work, and Bernie's helped me put some stuff in the chat, so really good to hear that's progressing and really positive. So the only other thing I wanted to say on this is that I was privileged enough to join the workshop last Friday that Toby ran and spend some time with him beforehand as well, understanding his vision for that, and just wanted to absolutely pay tribute both to Toby for his leadership in that, because it was a huge bit of work, that he led really well, but also to everyone that was there after a really pressured week, engaging really well, having some really powerful discussions. It was really nice to see some of the challenge, not just between the medical team and their nursing colleagues who were sort of paired together, but also between the specialties as well. So really positive culture I felt coming out from that session.
So I think Kim summarised strategically better than I could, so that was very helpful. I would just like to thank all of our partners. Bless the ambulance service, I think has been a truly excellent and understanding partner throughout the challenges. We're getting a lot of support nationally and regionally, which is really helpful. And being able to match what we do to the getting it right first time, the GIRFT standards, I think is both helpful and important. Because if we can map onto GIRFT and we still have a challenge, then we know there's more thinking we need to do. For those who didn't see the video, one of the patients said words to the effect that there's not enough space and there's not enough beds. Well, you might think that that's an uncontroversial statement, but to go back to what Kim said about the left shift, clearly it's a very important government policy and best for patients that we can move hospital care to the community wherever possible. But the challenge clearly we've got is that we have people ready to be discharged medically, but nowhere safe for them to go. And that's probably the biggest block, what I would say as a layperson. So we have to continue to work with our community partners on how we can discharge people more quickly into an appropriate setting. And I think, Kim, we would have to do all of those things. In other words, all of our professional standards, all our GIRFT compliance, all of the community facilities, before we could have a conversation about beds. We would have to very clearly demonstrate that we've done everything we possibly can to use the jargon to left shift into the community. If at that point it's still the case that we can't achieve what we need to achieve, then I'm sure you'll come back with some strategic options. I think clearly we're under national requirements to end corridor care, and we're not able to do it physically in the time that we were requested to or required to. I think, again, all I would say as a non-executive chair is could we at least show continuous improvement? You know, even if it's not complete abolition, we can start seeing a curve which is reducing corridor care consistently, rather than have a sort of zigzag. And then finally, from me, we shouldn't lose sight of the fact that thanks to the Herculean efforts of all our staff and everyone in the community, we have seen significant improvement in ambulance handovers and flow since this time last year, for example, but clearly not enough. So Joe has helpfully noted what we've been asked to note. I think we do have to note it technically because there's nothing for us to approve. It's work in progress. But I think we should note it with curiosity, with concern, and with a determination to improve through the measures set out on the agenda paper, if that's acceptable to the board. Okay, so can we proceed on that basis? Kim, did you want to add something?
Yeah, it was just a huge thank you to our staff as well as our partner staff. In the heat wave, they absolutely pulled together. And I know we had to call a business continuity escalation plan, but we had to make really difficult decisions collectively, and working with SWAST partners, especially with ambulances waiting on the forecourt, absolutely working collectively together made it more comfortable for patients, recognising the additional stress that colleagues were undergoing. But a huge thank you for that collectiveness. And we can see some of those thanks coming back from our staff, recognising the efforts we were making to try and make life easier as well, which was really important. Thank you, David.
Thank you, Kim. I'd also like to thank Cornwall Partnership, NHS Foundation Trust in Public as well.
Yeah.
And indeed all of the system partners. So if the board's content with that, we'll move on with thanks to Joe and the team who prepared the paper. Now we go on to item 9, the staff survey action plan. If there's anything you want to say first about this, Kim, that's fine. Otherwise, we'll turn to Alison.
I'll turn to Alison and then we can wrap up at the end.
Okay,
Yeah, thank you.
So could I turn to Alison Thorne-Henderson, our Chief People Officer, please?
Thank you,
Dual
Chair.
Chief People Officer.
Thank you. I just wanted to take us back very quickly for 1 second and remind us about the context of when we completed the staff survey in 2025. And that was a period of significant pressure and organisational change and restructuring across the Trust. So we had, as we have now, that continued operational demand, a large financial challenge, and the introduction of new divisional models and a reduction in some of our corporate functions. So let's fast forward to now. And we've already heard this morning about some of the great things that are happening across the Trust, particularly to support our culture. Despite the fact that we have gone live over the last week with our clinical administration review. But this is a very different type of change management in consultation. The board made a commitment of no redundancies. So whilst the divisions, as Joe has illustrated this morning, continue to embed and to make sure that all those vacancies are completed, we are really seeing now a move to a much more open culture where increasingly staff are speaking up. The culture change also is being supported by our acting chief executive, who's got a laser-like approach on our values at the moment. So the 3 points very quickly that I just would like to highlight to the board is first that in our pulse survey, our staff advocacy remains low. And whilst national evidence suggests that recovery takes time to shift, given the effort that we are putting in to support our culture programme, we would expect to see a change in those leading indicators this year. Secondly, the paper reflects the current trajectory, but again, once we have fully resourced all our programmes, we should expect to see a faster pace of improvement and ambition on our original metrics. The third thing to say is we are at the moment completely focused on the interventions that will have the greatest impact, and at divisional level that means the divisions are starting to make progress with their divisional staff local action plans. And from a communication perspective, again, Kim mentioned that earlier in terms of the you said we did, we've got to keep doing that and keep closing the loop with our staff. So there are positives. and we're starting to see some early benefits from our divisional model. We're also continuing our work on sexual safety and leadership development. So, for example, this week, myself and the Deputy Chief Medical Officer, we went to the launch of our Hive Potential scheme, which was about matching leaders across the system in mentoring, coaching, and an action learning set. So in summary, we're clear on the issues. We know we've got lots of work to do, but I think there's quite a bit of excitement now to make sure that we progress in ensuring that our staff have the right supportive culture and that we're able to change the dial on recommending the trust as a place to deliver care and to recommend as an employer. Thank you.
Thank you very much, Alison. Could I ask Richard Kramer to comment, because Richard chairs our People and Culture Committee?
Thank you, David. First and foremost, I'm glad we've heard from Alison, because I think Alison has given a real sense of positivity about what's happening to a great extent than the report. I think we've got the right priorities. I think we've got the divisions leading the work, and I think some of them are really storming. We heard them last time, and I'm really assured that there is that commitment and leadership to drive change. I think Alison's right to mention the visibility of the exec team and Kim. I think that is promoting a much more open culture. I've seen staff respond to that in a really positive manner. So I think what I wanted to say is we've got the right priorities. I don't think the report fully reflects the ambition for change, albeit I think Alison's narrative really does. I think the key point is we really need to see material improvements in the action plan. Otherwise, our programme won't be working, even though the staff surveys may lag because of organisational change. So I suppose as an action, it might be useful for Alison and I to revisit the metrics and then discuss those at the next People and Culture Committee so that we can match the metrics with that ambition, because I think we need to see improvements as quickly as possible.
Have comments? Ella.
Yeah, David, I just reiterate from what you said, really, from a point of view of obviously we have a wider culture transformation approach, and staff survey is very much part of how we're measuring that, the impact of that. So we've talked also at People and Culture Committee around when we're reporting on this and reporting on culture, actually we need to report on the whole. I think we can expand that, can't we, to make it clearer around the breadth of things we're doing on culture. So there are, for example, big step changes happening at the moment on things like we're going out shortly to look for coaching for our senior leaders. We have one and all sessions with Kim, which are all all staff trust forums where we can discuss things that are hot topic at the moment. We're really pushing and changing the way we do communication to ensure it engages better. It reflects how people feel. It's more of a two-way conversation in the organisation. In July, we'll have We Are RCHT Day, which is going to be the relaunch of our bite-sized training for managers and leaders, and an opportunity for people to come along and give real-time feedback around, is this fit for purpose? Is this going to help you? So there's loads going on around the culture more broadly. I think the paper today focuses specifically on the team's response to the staff survey, but we need to be sure, I think, that we're communicating everything we're doing more broadly around culture as well.
Thanks, Ella. Could we now go to Kim? I think it is.
It's a little bit like our urgent and emergency care conversation, isn't it? If we're not careful, we're going to boil the ocean. But actually, if we strip it back, it is about visibility, having open and honest conversations, because we're really clear, and thank you for opening it, Alison and Richard, for your support. Actually, we just need to make sure that we're not over conflating it, isn't it? Because actually it's quite simple for our staff. Would you recommend us for a place to work? Would you recommend that your family are treated here? For the staff survey, the overlay of culture Alison and I were talking this morning, it's like a beehive, isn't it? And how you trickle the honey through will fill the spaces, but it's not a freeway. So it's not road rage and everyone racing down. I would like to see that closer collaboration and maybe a joint report from Alison and Ella that bring all of those metrics together. There is so much work going on, but not always visible. And how do we, and I know Bernie's back from annual leave now, and we're working with Lindsay, how do we go out and be visible and not overload staff, but make sure that we've got the tools, we know what they've been saying, we're responding to that so it's not tokenistic is part of that. When we said senior leadership visibility, we don't just mean execs, we mean the new senior leadership teams in the division, and they're still bedding down. So I think it is about us keeping focused strategically, but I think sometimes we're seeing too many different reports coming through, and we need to bring that together that gives that holistic approach, not piecemeal. Otherwise, I worry that the improvement plans will grow, but it won't change culture. And we know there's some immediate things that we can do, and we can see that feedback coming through, and culture is longer burn, but it doesn't mean that we cannot and we should remain committed for our staff's sake in seeing that shift. And it isn't when I say just before the next survey goes out, actually we've heard what people are saying, we are taking actions, we just need to make sure that people are seeing that feedback, feeling that feedback that will inform the next survey.
Thank you, Kim. Could I bring in Niamh Lamond, Associate Non-Executive Director, please?
Thank you. Thank you. Sorry, apologies, everybody. Thank you. Well, first of all, it's really good to see such huge visibility from Kim. We see it in the updates we've got around whether it's Let's Talk, your walkarounds. I was just saying this morning that I attended the corporate induction on Monday, and the first person all the 30 new employees saw was Kim and Robin, and I thought that was really powerful in the way that she spoke about the values, the freedom to speak out, and I think really emphasised the importance of that staff experience and how staff are valued. So I thought that was very impressive. Couldn't say enough about what you've just said, Kim, about you said, we did, making sure those messages get back, that the voice of the staff in the survey have been genuinely listened to. I'm sure that's all understood. But these things are tough to shift. As you said, culture is a slower burn, but in terms of the survey and the issues that have come out, I'm assuming we're doing some pulse surveys, Alison, and are we getting any sort of more rapid feedback around whether we're shifting that dial ahead of the next survey?
Yeah, so we do a pulse survey every quarter, and at the moment it hasn't yet shifted. And I think that was what I was trying to bring out in the paper. However, it's a lagging response, the pulse survey, and I think the work that's going on, I'm expecting the next pulse survey to show a difference. We've got the full staff survey coming again in September. When we do a full staff survey, we don't do a pulse survey. I would encourage everybody to complete the pulse survey, because that does give us a bit of a snapshot of the are we heading in the right direction. Typically we don't get as much take up on the pulse survey as we do the full staff survey, but the pulse survey literally takes, well, probably 3 minutes to fill in. It's very quick to give your responses, so I really would encourage everybody to do so.
Thanks very much, Alison. Thank you.
I think just to put it in context, Alison, the paper mentions 281 people responded to recommending us as a place to work, and the 23% then would equate to 68 people. So, we have to bear in mind it's not necessarily a representative sample of 7,000 people.
Thank you.
Okay, who's next? I think the next one is Adam Broom.
Thank you. Thank you to Alison and Richard for the really helpful introduction to the paper today. Question, I suppose, links to the later paper on the People and Culture Committee Assurance Report as well. And Alison mentioned it in what she said this morning about the resources we need to deliver the staff survey action plan and the wider culture. We've talked about this a few times. Have we got the resources in place to deliver what we're saying we're going to deliver? And if we haven't, what's our timescale for having them in place?
So myself, Ella and Ian have met and we have a plan. I don't know if you want to go through the plan, Ella, in terms of resources.
Back on what we've agreed, if that's helpful. So we have one post in place already, which will continue. We need a further 2. We're going to be reprioritising other vacancies for this because we've acknowledged as a board that this is a priority for us, and we've committed as the corporate leads that we'll find those vacancies from within existing vacancies rather than any further kind of reorganisation. And then we have an element of non-recurrent expenditure for this to support coaching and other activities, for which we will be again taking that from within existing non-pay budgets to prioritise over this over other development areas. So essentially using other learning and development and courses, for example, budgets. And then we are also going to be talking to our colleagues in the charity around which elements of this they can support, but that will obviously be subject to going through a bid process to help us with that.
Okay, thank you.
We take one more comment from Ian, and then I'll try and build on what Kim said and sum up and see how we take this forward. Ian.
Yeah, just a very brief comment in terms of being curious about what the best do in terms of staff surveys. I didn't pick that up in the report, but there's lots of data available, as we know, through the National Staff Survey, and it might just be worth us making contact with, the top 5 performing organisations in recommending us a place to work to understand, is there are there a couple of snippets from them that we could reflect on? So I think just that, we've got lots of good ideas in here, but we wouldn't necessarily know all of the answers, and we should ask others.
Join the queue, beating a path to Northumbria's door. Alison.
On what do the best do, I had the privilege of chairing the regional forum for staff experience and staff survey results. Been a lot of really good presentations, but I'm also visiting Buckinghamshire and Berkshire, who are actually top of the leaderboard. So those visits are already in train.
Thank you for those contributions. Just a couple of random reflections from me, having listened to the conversation. First of all, partly thanks to you, Alison, for setting the tone. I think the tone of the discussion was more positive and optimistic than the paper, and I think that is as a positive. I think it might be better or desirable to build a stronger connection between the paper and the objectives and the national oversight framework, because the staff survey now is taking more prominence in the national oversight framework. And as our integrated performance report shows us, we're 127th out of 134 acute providers in terms of raising concerns, and 130th out of 134 in relation to the advocacy questions around would you recommend somebody to be treated here or to work here. So there's plenty of scope for improvement at pace. And I think if we had that linkage, it would bring the focus that Kim talked about on those particular questions, which probably are the most important ones anyway. One suggestion might be with Alison and Ella, and indeed Robin with his responsibilities for performance, bringing together the staff survey and the National Oversight Framework. We've moved from admittedly near the bottom of 1 to near the bottom of 2. If it weren't for the financial override, our average score would put us mid-table in 3. So we've got a bit of a burning platform on the National Oversight Framework. And there are only 10 trusts now in 2. So it's a smaller group. And it's only the fact that we're breaking even that's keeping us out of 3. So I think we do need a real strategic focus on the National Oversight Framework. And then there's a question of pace. The paper may be right in saying it takes 18 months to 24 months to see improvement. We haven't really got 18 months or 24 months. But we are very fortunate to have Kim, and there's been comment around the room of the real difference she's been making in terms of prioritising culture and staff satisfaction. And that gives me hope that we could see improvement when the next staff survey opens in September. And I do think we have to travel in hope. So thank you for all you're doing, Kim. And I think we're all seeing, as Neve said, we're all seeing that make a difference. So I'm just wondering, therefore, whether, in the light of everything the board has said, rather than noting this paper, perhaps we should refer it back to the authors for them to pick up the comments that have been made in board, perhaps take it again through People and Culture Committee, and either to the special board meeting we're going to be having in July or to the next private board on the 6th of August with a revised paper and a revised action plan which injects pace and passion into this process alongside resources and ambition. You'll have heard the debate, I know, Lindsay. Have you got anything to suggest by way of resolutions?
No, Chair, thank you. I think the report should be obviously taken as read, but with a clear action that we will refer the item to the July People and Culture Committee with an action to bring it back to August board with a revised action plan.
So you could take with that, Alison and Richard. So let's refer the paper back then, making sure that it reflects all the comments of the board, and People and Culture will come back to us probably in August with a revised paper and a revised action plan. Isabel, you would like to speak?
Yes, I'm sorry, I don't want to hold you up, David, but I totally agree with those proposed actions. I just wonder if it's also possible to get a further pulse survey done before that so that we could at least have some indication of whether we're seeing any improvement.
Yes.
Alison's nodding.
Yes, thank you, Isabel.
Yeah.
Thank you. Thank you.
I reflect on the fact that the full survey doesn't have great uptake. So do we need, as part of, so I agree, Isabel, but there's something in me about how do we do that, how do we engage people differently in that? Because it land in people's inboxes when they're busy, and I'm not sure it's hitting them in a way that they understand why it's important from our board discussion today. So I would just challenge us to think about that, but not taking away from your comment, Isabel, but just about how do we make it not just another pulse survey that's coming out, that we want it to, that we're clear it's going to feed back our board understanding of where we're at this point in time.
Whatever review is important, but if you've got a very small sample, it's difficult to build a policy on it. I think we had Ella, and then sorry, I was trying to close it down, but
we're thinking along the same lines. So we are talking about whether we can make that full survey monthly rather than quarterly. And at the moment, quarter one would be measured in April, which to me is a bit counterintuitive. You'd expect quarter one's results to reflect what you've done in quarter one. So we're just looking at the timings of that. And Christian, obviously, who's our people engagement lead, is now sitting within the comms team to try and help with that kind of how do we use the full range of skill sets we've got in the comms team to help him and support him in getting the better engagement in things like full surveys. So we'll have a rethink around how do we make sure those surveys land and people understand the importance of them giving up the feedback, because yeah, you're right, we need a good sample so that we can build our policies and approach in a way that's going to be most effective and be what people want to hear and see. So yeah, we'll take that away as an action.
So we're getting a bit operational now, although it's important. We've got a way forward. Are we happy to proceed on that basis? Okay, thank you. So we'll refer it back to People and Culture, and it will come back to us. So That then takes us into section B, which is the reports and matters arising from committees, and particularly matters that have been escalated from committees to the boards. So we always ask the committee chairs to summarise their reports so we can avoid long executive introductions. So could I go to, on the Quality Assurance Committee board report, can I go to Isabel Down, the chair, please? Isabel.
Thank you, David. And I will try to keep this succinct on the basis that I'm assuming that everybody has read the report. It's to summarise the things that we've escalated through to board, one of which is the ongoing monitoring of cancer performance, where I think as a quality committee, we're keen to ensure that we're maintaining improvement around some of those metrics. And I think, as we've already discussed, there's been ongoing concern about UEC performance, and particularly the no criteria to reside numbers. So again, I think that's been well debated today here at board, so I won't dwell. Summarising just the May and June issues from the meetings that we've held. In terms of health and safety, we've managed to close down some actions around both fire safety and asbestos management, both of which had issues that were concerning us over a period of the last few months. The next one to highlight really is our stroke service, where we continue to really show concern at the lack of progress, particularly around the demand and capacity work that the ICB are undertaking. We're still struggling to try to find when we're going to see the results of that work, which will help us in terms of the planning of our improvements to stroke services. So we're hoping that won't take too long. We have spent quite a lot of time in the Quality Committee looking at the importance of minimising harm. And I'm pleased to say that at the moment, we're not seeing evidence of harm in relation to corridor care, which I think is important to understand, because obviously we're struggling with our numbers in corridor care, but also underlining the process that the divisions are now taking on in terms of looking at monitoring harm via their performance review meetings. So I think the committee are taking quite a lot of assurance around the process to monitor harm. Very importantly, Bernie brought to the last Quality Committee some slides which outlined the impending publication of the National Quality Strategy. And I think that we will be doing some more detailed work around that as it's published. And I don't think it's yet been published, but it's due any day now. So that's good. We're still registering a lot of concern about our fracture necrophema, which, as we know, is one of those areas that improves and then deteriorates and then improves and deteriorates. So we've got ongoing concerns still about the length of time it's taking to get our fracture neck patients to theatre for surgery. So we are bringing that back to committee again next month to have a further look at that. We're recommending that the board approve the health and safety strategy. And what we have requested is that, without holding up the approval, to request further consideration of how we build in equality into that strategy, so that we are really thinking about our health inequalities when we're thinking about our health and safety. And finally, it's already been mentioned, and it will get mentioned, I'm sure, within the perinatal report, which is on the agenda, but just to note that we've had we're in receipt of the Baroness Amos and the Ockenden reports. There's a separate agenda item to look at that. And also, as Becky mentioned earlier, we now have the 10-point plan, which I think is going to be really critical in terms of following what we need to do next around our maternity services. So I will stop at that point and take any questions.
Thanks very much, Isabel. Very succinct. Are there questions and comments for Isabel, please? Any hands going up? So if not, I think that's covered it very well. Thank you, Isabel.
Thank you.
And you've covered the items which you wanted escalated to the board, or we've already considered them in relation to urgent and emergency care. So that means we can go on to item 10.1, the Learning from Deaths Q4 report. And could I turn to our Chief Medical Officer, Mary Kane, please?
Thanks, Chair. So the report you all have seen is 34 pages long, so perhaps not in the spirit of a shorter report. I'm happy to take feedback offline about whether by the time it gets forward, it would be appreciated to be shorter. But for this time, I have kept all the information in, but will give you a short summary. So overall, our hospital mortality remains within expected limits, and there are no organisational wide mortality alerts, with hospital summary mortality ratio, summary hospital mortality index and crude mortality all triangulated to make sure that they are aligned. As Isabel has already mentioned, fractured neck of femur mortality is still the principal hospital summary mortality ratio, mortality outlier. However, it's recognised nationally that this is a less good marker, and we are better guided by the National Hip Fracture Database mortality data. We are within the control limits for the NHFD mortality measurements. However, we are still having a mortality of 6.1% versus a national average of 5% within that marker, and time to theatre remains a challenge. So prompt surgery nationally, and prompt surgery is surgery within 36 hours, prompt surgery nationally is being achieved at an average of 57% of patients. We are still only achieving 45%. We will continue to work to improve this. It is noted that we are the 13th busiest centre for managing patients with fractured neck of femur in the country, and that isn't matched by size of our team or resource, and this is something we need to look at. There were 3 learning disability 3 deaths of people with either learning disability or autistic spectrum disorder in the quarter, 4 deaths of people with severe mental illness, and 4 perinatal deaths within the quarter. And these will all be subject to structured judgment reviews. There were no child deaths or clinician escalated deaths within the quarter. Learning from patient safety reviews in the quarter highlighted themes around communication, escalation of deterioration, medicine safety, governance and care coordination, and all will be incorporated into learning to go back to the clinical teams. There were 36 structured judgment reviews undertaken during the quarter, with nearly all cases assessed as having good or excellent care. There was, however, 1 case that demonstrated evidence of avoidability, and that has resulted in a monitored safety action plan. Mortality governance processes have been strengthened following the divisional restructure, and that includes standardisation of mortality and morbidity meetings, on which there is a continued focus, and a process change in undertaking structured judgment reviews to ensure they are more robust and timely. So in summary, mortality performance is within expected limits. There are robust processes to take the learning from each case, and there will be a continued focus on ensuring translation of that learning into improvement. Happy to take questions. Appreciate there's a lot of information within that report.
Thank you, Mary. I mean, I know I'm supposed to be the one who's arguing for shorter papers, but I always think this paper is brilliant because for a non-executive, it provides triangulation. And given the importance of the subject, 30-odd pages, doesn't seem too long. I'm sure board members can feed in.
Yeah, I'm very happy to take feedback on that.
So are there any comments or questions for Mary on the board? I think that's a compliment to you, Mary, because it is so comprehensive. All the questions we might have, every question I have as I read through it is answered as you go through. So can we note that report? I don't think there are any actions arising from what Mary said. But of course, we note the fractured neck of feedback.
It's not Mary and I.
Our computers are dying. That doesn't appear to be working.
We are on, so if you want a pass plug, we can connect you.
Yeah, okay. It has. Oh, it has. Well done. Thank you. That wasn't so difficult.
The combined brain power on the front bench wasn't able to turn a switch from off to on. As ever, we're very grateful for technical support. We're back in business with renewed energy levels.
We're on.
Okay, so after that lacuna, I'm just checking where we are. We now go on to item 10.2, the maternity and perinatal safety report. And Bernie, could I ask you to invite this, please, to introduce this, please?
Thank you, Chair. So the report provides assurance on the safety of our maternity and neonatal services. Key positive indicators for May include zero stillbirths, zero neonatal deaths, maternal deaths, no MNSI and zero MOS alerts. We had no service suspensions, no induction delays greater than 24 hours and no uncovered cesarean lists and no new red flags. And we reviewed that in detail at QAC with no escalations to the Trust Board. I just want to highlight the NHS Resolution Scorecard. It showed no new identified trends, but I think importantly, it shows the improvements of actions taken, particularly around learning from bladder injury incidents, and no bladder care related cases have been identified, and that has been high in terms of our litigation profile before. I also want to flag that the perinatal mortality cases were complex and they received appropriate multidisciplinary, importantly, bereavement support, psychiatry and statutory support where required. The new maternity care bundle tool has been received and we are working through that alongside primary care and commissioners to continue to provide joined up care for Cornwall. And in the new 10-point plan that has been issued this week, we need to do full implementation of the maternity care bundle now by March 27. I think the other element I just want to highlight is survey user feedback and the voice of women and their families continue to shape improvement. Kerno Maternity Neonatal Voices Partnership remain actively involved in our co-production, maternity walkabouts and feedback, and our neonatal feedback remains positive with further work planned to capture family experience through the QR code, and we'll see that coming through the board. We've had no complaints to maternity services halved in May, and we had no neonatal complaints. And then the final bit I just want to raise is around culture and inclusion. There have been some concerns raised about racism and discrimination, and I'm really pleased that those were escalated directly to the senior leadership team and to Josie Dodgson, our Director of Midwifery. Both her and I have spoken personally to the individual that has raised those concerns to thank them for sharing those, and a multidisciplinary steering group is being developed to apply the Just Culture Principles, review themes and co-produce together an anti-racism and anti-discrimination action plan for maternity, which the whole team, and you will have seen that when the quad came to board, are absolutely committed to. So thank you.
Thank you very much, Bernie. Kim.
Thank you, Bernie, for raising that. Whilst it's really disappointing, and we all feel that disappointment, and we can see that reflected in the inequity and discriminatory practice in both of the reports we've seen, it is with maturity that the person correctly raised it, has been supported, but most importantly, how the senior team have been proactive, open and transparent in making sure we're making the right changes and having the right conversation to be able to make sure that our service is more inclusive. I think as a trust and probably as a system, as our population becomes more diverse, we have to make sure that we are culturally inclusive and we have the right education and support and toolkit to be able to support our staff. So whilst really disappointing, very, very satisfied with how it's been received, how people are being supported, but most importantly, that commitment to change.
Thank you, Kim, for that leadership statement. Isabel.
Thank you. It isn't a comment or a question around the paper, but I would just like to take the opportunity to say how impressive our Director of Midwifery is. She comes to our Quality Committee every month and delivers this report. And for me personally, she inspires a huge amount of confidence that we are covering what we need to cover in terms of our maternity and neonatal services, both in terms of our scrutiny and gaining the assurance that the services we're offering are safe, and that we are willing to open ourselves up to vulnerability and looking at those areas that perhaps might have produced different outcomes. So I think Josie's doing a fantastic job, and I just wanted to pay tribute to her and her team.
I'm sure we'd all echo that. Becky.
I think it's Usma first.
Sorry. Oh, Usma, I beg your pardon. It's Usma first, then Becky.
Thank you, Bernie. Richard has put in the chat one of the comments I was going to make to see whether this could come to PCC. Thanks, Richard. And I also wanted to just find out how the board will be able to know that the work, the action plan on the racism and discrimination is having an impact on staff experience and their psychological safety. So maybe coming through to PCC would be the best way to monitor that. Thank you.
So we will bring it through PCC, and also it'll come up through the perinatal report as well. We'll bring it through both routes.
Okay. Now to Becky.
Thank you very much, Chair. And I would certainly support it going through both routes as well. Thank you, Bernie. In addition to that, I was really pleased to see some aspects around health inequalities with regards to the specific cases that had been reviewed, looking at a very basic measure, actually, which is still very impactful, which is the index of multiple deprivation by postcode. It's a 5-second search on Google. It's a 5-second thing on to get that multiple deprivation decile, and actually provides a huge amount of information on what the wider context of that patient is. And we can expand that further. And I think that is reflected very timely in Jim Mackey's 10-point plan to have a perinatal equity and anti-discrimination programme by the end of 26 with inequalities data dashboards at board level. So I think both within maternity and perinatal, but also we can expand, we could be expand it further into other case reviews, structured judgment reviews, and learning from deaths. We know that for learning disability and autism, for example, men with learning disability and autism die 23 years younger than average adults population, and females 26 years younger, and patients with significant mental illness between 15 to 20 years younger. So that, and that also unfortunately is reflected in the ages of the patients who we are seeing on those case reviews as well. So it'd be really great, I think it'd be really great to have some more population health data, and certainly I've been speaking to Calvin a little bit more about how we can achieve that, and also basing that around the core 20+5 frameworks as well, to reflect ethnicity, significant mental illness, learning disability and autism, and exclusion groups, of which we do have a number in Cornwall, both sort of traveller communities and even and vulnerable migrants, but also remote coastal locations as well. So I think it's very timely, and I'd really like to have that within the board papers and consideration when we, not only just for the board, but also wider as well within the organisation. You know, if you've got somebody who's age 60 who's coming in with a learning disability or significant mental illness, that we're thinking about that as we're seeing them as well.
Thanks, Becky. I'm really glad you raised that, and I know it's something Richard has been very concerned about, and we see it reflected in the Learning from Deaths report as well. The Integrated Care Board does have an overall responsibility for leadership on health inequalities, but we'll be looking at a consultancy report this afternoon which lays out starkly for us the health inequalities in Cornwall. So I don't know what you feel, Kim, but it does seem to me that one of the dogs that doesn't bark enough at board meetings is health inequalities, and that with our partner trust and with Cornwall Council, there is more we could do with the ICB to provide leadership on health inequalities and deeper understanding, and also hopefully more reaching out to those communities to try and minimise the inequalities that are very apparent in the data. So exactly how we do that, probably we need an offline discussion, but I think you're absolutely right to raise it, and it's something we should take very seriously indeed. I know Adrian wants to come in, but could I just ask Kim if she wants to say anything about that, please?
No, I think we've got to make that link more widely in most of our reports. I'll pick it up with Ella as well, because we talk a lot about it, but if you looked at any of I think our reports or minutes, could we put our finger on it? No. We know we're all doing a lot of work around it, but could we show that? No. And whilst we know that is a system issue, how we bring that in, especially with some of the conversation on the reports we have later this afternoon, I think it's key critical we start to reflect it. Even talking about urgent and emergency care and access, we could see that differentiation between the most vulnerable and was it the right place? So it's making that connection. So I'll pick that up, David, that we can start seeing that connectivity throughout.
So one of the things I learned during the interviews the other day, sorry, I'm starting to get operational, was that in the emergency department, they don't have access to the mental health IT systems. And so they can't review medication or, there's lots of things they're not able to do. There are disconnects.
Yeah.
So can we pick that up in the way that Kim suggests, please? Adrian.
Yeah, many of you will know that one of my mantras is that as an organisation, we should celebrate success more. Bernie, you mentioned in your paper about complaint, as we do in lots of papers that come to committees and boards. Adam and myself attended a workshop earlier this week on the Women and Children's new hospital, and we were talking to a member of staff, and they asked the question, why don't we report compliments and plaudits? Which I thought was a very good point, because you can learn as much from an event that's gone well as you can from one that's not gone well. So it's just a challenge I wanted to put out. Thank you.
We capture that information, how we present that back. We do capture compliments organisationally and at divisional and specialty level.
We're probably not very good then at promulgating them, are we? Thank you. I have asked Lindsay, although appreciate it's a lot to do in a board meeting. When we come to the section on risks that have arisen during a board meeting, I've also asked Lindsay if she can also to tell us about things we should celebrate as a result of the board meeting, which I can take it to the podcast that I do, or Kim does it with me, with Peter. Okay, is there anything else on that, Kim?
No.
Or Bernie? You're happy with that? So in terms of the board resolutions, we've been asked to discuss for assurance the discriminatory conduct. And I think we need to have a resolution saying that we're referring that to People and Culture Committee for further consideration. Apart from that, I think the resolutions are as set out on the agenda paper. So what I'd suggest is we do 10.3 health and safety, and perhaps we have a 15-minute break and come back and do the Finance and Performance Committee and the other agenda items. Is that okay? I think you've all deserved a break. So 10.3 is the Health and Safety Strategy, which has carefully been through the Quality Assurance Committee, but is coming to board for approval. Bernie?
Yeah, it's for me. Thank you, Chair. So, yes, as you said, it's been through the Quality Assurance Committee, and I would like to thank them for really robust. It's been scrutinised at depth, and some of the feedback that they gave us that they would like further development on reporting relating to health inequality. So that piece of work is being picked up. The proposed health and safety strategy, it is a mature, comprehensive strategy and appropriately aligned to both statutory requirements and the wider organisational priorities. It tries to move us beyond the trust, beyond a reactive approach focused on compliance, towards a more preventative model centred on leadership, learning and staff wellbeing. the principal challenge for the organisation is likely to be implementation rather than design. So we've focused very much on making sure that the strategy adopts the recognised plan, do, check, act methodology, creating a structured approach to continuous improvement and organisational learning. It does include a safety improvement plan within the report, and we're going to make sure that the reporting, the quarterly report, focuses on the 6 or 7 key topics that we need to include on that, which is workplace injury and sickness trends, incident and near miss reporting, risk assessment compliance, which we are improving, and statutory and mandatory health and safety training compliance. The fire estates and infrastructure compliance is also a key part of that reporting and monitoring that we will be undertaking, and contractor assurance metrics. We need to increase some of our contracting to make sure that we are meeting some of the deadlines that we need to meet to ensure over the next 3 years the strategy stays in line with our plans. Equality impacts and workforce safety outcomes, as we've said, as I've just said, we are going to do a designated piece of work to reducing inequalities across all of our services. So the strategy provides a robust framework for strengthening health and safety management across the trust. It supports compliance, workforce wellbeing and organisational resilience. And whilst creating a clear structure for continuous improvement, the key test over the next 3 years will be consistent implementation. It is to note that whilst the trust operates a single trust strategy and works to avoid having multiple strategies, there is a requirement for the trust to have a designated health and safety strategy. So, yes, we would ask the board to approve this today.
Thank you very much, Jo. And as you say, it's a statutory requirement. Adrian, any comment?
Just to say that I have regular dialogue and meetings with Rob, with Gavin and the health and safety team, and also with Brian and Richard with regards to fire safety. So I will continue to carry those out throughout the life of this strategy.
Thanks, Adrian. Thank you. And it's good for us to know we've got your expertise behind it as well.
Thank you.
Ian?
Yeah, very happy with this. Just to note, Appendix 3 looks like it's got some formatting issues. So just to make sure in the final version they're addressed, but otherwise very supportive of it.
Excellent. So this has been through Quality Assurance Committee. Sorry, Alison, did you want to come in?
Yeah, I was just going to pick up. There's some job titles that are no longer relevant, need updating. Thank you.
Might need a final proofread to tidy things up. But on the assumption that that's done, it's been through Quality Assurance Committee. Jo's given us a full introduction. Adrian, as an expert in the field, has provided us with some assurance. So is the board happy to approve the health and safety strategy, noting that further progress will be reported through Quality Assurance Committee? Board content? Thank you very much. So we've got an approved strategy there then.
Thank you.
Jo, subject to those changes that we discussed. So could we take a break at this point for 15 minutes? For those people in the room, there's a cafe in the basement. For those people at home, I'm sure you can make your own arrangements, and we'll reconvene. Shall we say at 25 to? Thank you very much. So welcome back, everybody. I hope we've all got our power switches back on, and we can move forward on the second half of the agenda. The first item to consider is the report from Finance and Performance Committee. And could I ask Adrian Davis, the chair, to introduce it, please? Adrian.
Thank you, Chair. As I mentioned earlier on, I think I'll start with a couple of compliments. We've seen a great improvement in the quality of the papers that are coming to the Finance Committee. You may have noted some of the papers later on in the finance section, the way that they've changed over the last 2 or 3 months. So big thanks to those that produced the papers. I'm going to take the report as read. You can see that there are 6 items there that the committee recommended to the trust board to approve. The main focus of our conversations around the last two meetings have been linked to risks associated with the e-care delay, the impact on that with the capital plan for this year and potentially longer. And we've also asked for some further information with regards to corridor care, but other data sets that impact on segmentation. So those are the main things that that we've covered, and I'm happy to take any questions.
Excellent. Thank you, Adrian. Are there any comments or questions for Adrian, please? Anything coming up on the screen? So you've escalated the risks associated with the e-care programme, which we are aware of, and we'll be considering that further this afternoon because it's a commercially sensitive issue. Apart from that, I think we only have to receive and note the assurance report, Lindsay. So can we do that, Board? Thank you very much, and thank you and your committee, Adrian.
Thank you.
So that takes us on to item 11.1, which is the month 2 revenue financial report. Ian.
Yes, thank you, Chair. So I don't want to take too much time on these first two items to leave more of the time for our medium-term financial plan update to public board. So the paper's taken as read. Page 193 has a very clear summary of our financial position after 2 months of the financial year. We had a break even in the individual month of May, but we remain off plan cumulatively by 420,000 linked to the industrial action cost that we saw in April. As part of the work that we're doing at the moment, we're looking at how we can mitigate that, and board colleagues will be aware that the further industrial action that was scheduled for June was stood down prior to it happening, and subsequently a pay deal has been reached. So we hope that from a risk perspective, that risk has reduced now in terms of going forward, and we will be looking at what options we have as an organisation to mitigate that current deficit to plan of 420,000. I think at this point, it's really important just to remind our board and public about the shape of our plan. So it starts with deficits, and as our savings target increases through the year, it moves into surpluses, as you can see on the graph in the paper. So the key thing is that run rate of expenditure and how we ensure that we're getting the delivery against that. That was a key focus of the discussion at FPC. Our escalation capacity that we've got open to help address some of our UEC challenges that we referenced earlier is one of the contributors to adverse financial impact, ensuring that those areas are fully staffed and appropriately looked after for patients in those areas. The key focus really next is on our forecasts, so looking towards the end of the year and what mitigations we've got. That was a clear expectation we've set, and they'll be reported for the first time this year through FPC later this month. And we've got the quarterly performance review meetings with each of the divisions coming over the next couple of weeks. And again, the key focus of that financially will be their forecast and their actions that they're taking to make sure we hit that trajectory that I've referenced to. The only final bit that wasn't in the report, just to update on, is that the regional NHS England team are starting to undertake, and they did a bit of this last year, but they've formalised it a bit more in terms of what they call risk assessment matrix. So looking across a number of indicators of our financial performance, including cash efficiency, I&E position, etc., to judge against others in the Southwest about how and where they intervene. So we'll bring more details of that through Finance and Performance Committee in July and then subsequently to board, but just so that board's got that early oversight that exists. That's not that's not changing from anything that's in the segmentation, but just a supplementary that the local regional team are doing, asked by the national team. So I'll open it up for questions at that, Chair.
Thank you very much, Ian. Ian, do we know if the settlement with the resident doctors will be fully funded by government?
We don't yet. No, we haven't seen that. I would expect it to. through what they call the cost uplift factor that they apply to tariff prices, but we haven't had that formally confirmed.
And the 400 and odd thousand, which we've already incurred, would we get any help with that, or will we have to breathe that in ourselves?
But at the moment, organisations are being asked to take all steps to mitigate that locally, and that's what we're looking at doing. Last year there was some for it, but last year it was over a more sustained period. I think we had 3 episodes last year during the financial year. So we continue to ask that question, because obviously we've got a significant risk in our delivery of our plan without that. So it is something we continue to put forward, Chair.
So, I know you've said this to FBC, but given we're in public, that's an additional pressure as we sit here today.
Yes, correct.
Thank you. Are there any comments or questions for Ian, please? So if not, thank you very much for that report, Ian. And if we could now go on to the public part of the medium term. I'm sorry, we go on to the capital report first, then we'll go on to the medium term financial plan. So 11.2 is the month 2 capital report.
Yeah, so the month 2 capital report, again, take as read. I think only 3 things really to pull out for this one. One is that the substantive conversation will be the reprioritisation of the capital programme that we've got on our board in private agenda this afternoon. For the points you raised earlier, Chair, regarding the delayed CE care and the financial risk capital-wise that presents. You'll note in the paper we've increased the risk score in terms of living within our capital resources as an organisation from 16 to 20, and that's in relation to that paper that we'll be considering this afternoon. And then the final part of the paper is the request to approve receipt of 323,000, which is part of the enabling works for Women's and Children's new hospital programme, which again is a really positive confirmation to have received from the new hospitals programme in terms of backing that scheme and some of the vital works that we have to do in terms of changing and moving cabling across our site. The variances in the report I'll leave as they are, but would just recognise that they will change materially when we have the updated capital programme. And I'll leave it at that, Chair, unless there's any questions.
Thank you, Ian. Questions or comments for Ian on the capital report? So both in relation to revenue and capital, we're asked to note all the items set out on the agenda paper. And we're also asked to approve the receipt of the £323,000 in relation to the Women and Children's Programme pathology scheme, the 11 kV cable. Board happy? Thank you very much, and thank you, Ian. So that does take us on to the medium-term financial plan, where we take a forward look at our sustainability. Ian?
Thank you. So firstly, I'm delighted that we're bringing this to board in public today. And particularly for members of the public and colleagues watching online, this is our medium-term financial plan, and essentially that sets out what we're doing to secure our long-term financial sustainability over for the Trust over the period between now and 2031-32. It's a key enabler for our Trust strategy and our ambition of delivering outstanding care for one and all, to make sure that our financial plans align to our strategic plans. We've had an MTFP for a number of years, and it's developed quite significantly over those years. This is the first time we've created a public-facing version, and hopefully for board members and members of the public, it's helpful to understand at a reasonably detailed level, but an overall level, the sort of scale of challenge that we're looking at. So delighted to be able to share it for the first time in public. The headline message is quite simple, that there's a significant challenge, which I don't think will come as a shock to anybody. But it is one that we believe we can achieve through sustained improvement in productivity, in efficiency, and in the way we deliver services, linking to the 10-year plan and some of those key shifts that we've talked about. The planning timeframe in this starts from the balanced financial plan, so that's a break-even position that we've set in 26-27, and looks to maintain financial balance over the 5-year period of the plan. But that requires substantial recurring savings, so that's savings that you deliver year after year. and the document talks about some of those definitions to help people. Put it into context, this year's plan requires us to deliver 42.5 million of savings. Beyond that, in the model, you'll see that there's a further 33.7 million next year and 24.3 million the following year. That reduces because we deliver in the planning assumptions a level of recurrency. And I'll come on to talk about that in a second in terms of some of the risks with that. It's important to say this isn't a plan about cutting services. It's a plan about improving financial sustainability through productivity, reducing waste, better use of technology, improving patient flow, reducing that variation that we know exists in how care and services are delivered, and generally ensuring that every pound that we spend delivers maximum benefit for our patients. It's not also just about the savings that are required to deliver that break-even revenue position. The paper talks about our capital investment over the period. Over the next decade, we're planning approximately £627 million of capital investment, predominantly through the new Women's and Children's Hospital that we've already referred to in our meeting, but also importantly, improving our wider estate, replacing medical equipment, and continuing our digital transformation through both the go-live of our new electronic patient record e-care, but also beyond into ambient voice technology and other new technologies that are emerging. So important that the board and our wider public are aware that this plan contains risk and uncertainty. It's based on assumptions, it's based on successful delivery of our financial sustainability programme, continued productivity improvements, and several national funding and planning assumptions, particularly around some of those capital investments that we've talked about. The paper is transparent about those risks, and we've included some sensitivities and scenarios to understand what sort of variation there could be to the plan. And that's set out in the paper, because one of the challenges that we know in the plan is the level of recurrency that we get in terms of our savings. So it is possible those savings in future years could be higher if we don't deliver enough recurrent savings in each of the years. We should, however, take confidence from the fact that as an organisation, we've got a strong track record of good financial discipline. We haven't been in receipt of deficit support funding. We've achieved a break-even or a surplus position as an organisation in every year since 2019-2020. And this plan builds on that foundation, demonstrates a credible route towards financial sustainability, and demonstrates the level of continued investment in the healthcare of Cornwall and the Isles of Scilly. So I'll pause there and happy to take any questions, but would really welcome feedback from the members of the public either today or in future to the document that we've shared.
Thank you, Ian. Could I just thank you and your team for a very impressive professional piece of work. Just to remind the board, we're also working on medium-term workforce plans and on a medium-term infrastructure plan, which would give us a set of enabling medium-term strategies to underpin our clinical strategy, which should give us a good strategic overview as a board, not only of tomorrow, but of the next few years. Are there comments and questions for Ian on the strategy? I know we've discussed some of it before. Would you like to say anything? Oh, sorry, we've got some on screen. Could I pick up, first of all, Richard, and then we've got Uzma, and then we've got Neve. Richard first.
Yeah, thanks. First and foremost, it's a really, really excellent report. It's actually an enjoyable read, but also it's really good that we've made this available to public board. So thank you. Just on picking up what our chair was saying, on page 225, we talked about the medium-term workforce plan will be updated along this plan. And I think in order to capture recurrent savings, it's really important that we design the workforce around our future health needs. So I just wanted to know when and how we're going to integrate both plans together so that we're looking at new models of care, new pathway of care, and a workforce that looks at system solutions.
Alison, do you want to come in on that?
Yes, thank you. So the medium-term workforce plan, as it is currently drafted, draws upon the intelligence that we have at the moment and integrates with our finances. So Helen Lewis works very closely with Graham and others from the finance team on the current medium term. However, that future piece we are addressing in a integrated workforce plan, which is due to come to the next People and Culture Committee, and that starts to shift the dial and will continue to be needing to be updated, but that very much does start to look at future skills, starts to move into the rounds of what does it mean with neighbourhood working.
What sort of staff will we need?
Yeah.
What skills? Yeah.
Exactly. Thank you.
You very helpfully highlighted the role of technology in productivity. What we're seeing in terms of future national funding is quite explicit expectations of the contribution of that to productivity. We probably would expect to see asks in the future for national reporting around that element of it. So maybe that's something we should pick up in terms of future development of the plan.
Thanks, Kelvin. Could we go to Ursula now and then to Neve?
Thank you, Chair. First of all, Ian, thank you to you and your teams for producing this report and actually all the hard work that's gone into getting us to break even these past 7 years. I wondered if it would be helpful for you to kind of share with public members how that position of break even has benefited the trust, because I thought that would be helpful, but also maybe to explain what you mean by recurrent savings, so members of the public can understand the difference between that and non-recurrent. Thank you.
Yeah, thank you, Usma. So if I take those, so thank you for the thanks, and I will pass that on to the team, because I sit here taking credit for work that's being done by my excellent team, and in particular Adam Wielden, who's done a lot of the work on this one. So in terms of the recurrent plan, we've got that in section 1.4 about questions people often ask. So hopefully that's helpful for members of the public. So essentially, whilst one-off savings can help in a single year, they don't fix our underlying cost base. So recurrent savings are important because they carry forward and reduce the size of that. So an example of that would be not spending some money on something and just delaying it is a one-off measure that might save some money, but actually transforming the kind of staffing structures of a team or a department to benefit, or using technology, as we've talked about by Kelvin, to change how transactions happen, then allows us to take a cost out on a recurring basis, or permanently, essentially. So hopefully that's helpful. In terms of how the trust has benefited, a number of ways. So two specifically on our delivery of the break-even position was receipt of additional capital, which is helping us address some of our capital challenges this year. So incentive capital aimed at those organisations that do that level of financial delivery and discipline. And we also benefited from the redistribution of deficit support funding, colleagues will remember from a board perspective, which essentially was money that nationally was withheld from organisations not delivering good financial sustainable practice, and that was given out to those that did deliver that. We benefited to the tune of nearly £5 million last year from that. We couldn't spend that money because it had to offset an overspend elsewhere, but it meant we could report a surplus position. We received the cash, which helps with our longer term sustainability, and we also had it reduce our cumulative deficit as an organisation that exists from years prior to 2019, 2020. So hopefully that helps us, just to give a bit of a flavour for colleagues and the wider public in terms of some of the benefits we have seen from our delivery to date.
Okay.
Thank you. Yeah, excellent report. I suppose I'm just looking at the, you said that the most challenging year is 27, 28, the 33.7 million. And then you talk about the 6 themes for achieving the savings. And I suppose it's just, and that's, I think, on page 11 from memory. Yeah. there are 6 themes. Do you have sort of detailed plans around pay and non-pay savings, recurrent and one-offs under those themes by year that actually demonstrate that we've got the capacity to deliver that change, and also if there are upfront investments in delivering that change, that we have accounted for those as well?
Yeah, really good question. Thank you, Niamh. So we have our financial sustainability programme that we established prior to the start of this financial year. And from a governance perspective, there's a board financial sustainability programme board, which Kim as Chief Exec chairs on a monthly basis. We are developing that more into the medium term space. So historically, I think board members will be aware majoritarily that we've tended to focus on this year's savings programme, but as part of our work programme through the FSP board, we've got a multi-year view of that. And essentially we have, themes, and then under the themes, the specific schemes with exec SRO leads, but also scheme leads. And what we're trying to do is move to get to more of how much of that 33.7 million for next year have we got kind of thinking about and ready now, rather than waiting until we get into January, February next year for delivery in April. And that financial sustainability programme's focus is on about that medium-term financial sustainability. So your examples of actually a change in a process or a pathway may require an element of investment to achieve that is part of what gets considered when we do what we call the project initiation documents.
Thank you very much. And are you confident that the savings in year will be achievable?
So they're really stretching. They're nearly 6% of our turnover. I can remember the days when 2 and 3% was a stretch from an efficiency perspective, but it's a level we've delivered last financial year. So I wouldn't sit here saying it's comfortable. That's one of our key risks in terms of the ability to deliver that in the way that our plan gets more challenging as we go through the year. But we monitor that through the FSP board and through Finance and Performance Committee.
Thank you. Thanks, Ian.
Thank you. Any other comments for Ian? So if not, can we, with renewed thanks, endorse this medium-term financial strategy, Ian? And obviously we'll keep it under review as the real world changes over time. Thank you very much. And if you could pass on your thanks to the team.
I will, thank you.
Thank you. That takes us on to item 12, the People and Culture Committee Assurance Report. Richard.
The things I wanted to share were, first of all, we talked about overall sickness absence, and whilst that had reduced, stress-related sickness has increased to 30%. So the committee asked for a deep dive into sickness absence, including stress-related absence, which will be considered at the committee this month. We've already discussed the staff survey, and just to reiterate, it's really important that staff experience visible change to believe that the trust has listened to them. We also discussed appraisal and training compliance, which has continued to fallen, and we also raised concerns about the trajectory of Oliver McGowan training, and we asked for greater assurance in future reports. These are basic governance and safety issues, not just HR metrics. We also had an update on the culture transformation programme, which was very well received, and it was important that future reports are focused on implementation and outcomes. As Adam said earlier, we did feel the need to escalate the need to secure appropriate resources for organisational development, culture, and also occupational health. And we said these functions aren't just nice to have things, they're real core enablers of staff wellbeing, culture change, and safe delivery. And finally, we noted positive developments around our work on sexual safety in terms of policy, in terms of learning, in terms of training, and quarter reporting on cases. This is an area of positive progress, but we want in future more information on lived experience, learning, and cultural impact. So they're the things I wanted to share. Happy to take questions.
Thank you, Richard. Adrian?
Yeah, just with regards to training compliance, I noted in the health and safety annual report that's in the papers as a starred item later on, that there appears to be a correlation between reduced levels of training compliance, particularly in regards to health and safety, and an increase in reported incidents. So I would ask if you could look at that when you do your deep dive on training, please.
That's really helpful. Thank you.
Comments? So, thank you very much, Richard. Was there a comment? Was there?
Yeah, just
Alison, sorry.
That's okay. Just one quick comment to say in terms of appraisals and stat and man training compliance. This is just something that we are discussing in the people meetings as part of the PPPPP 5Ps performance meetings with the divisions. Thank you.
And then we've got Neve and then Becky. Neve?
Yeah, just firstly on the sickness absence reporting, I'm sure this is something you do at the People Culture Committee, but how does that benchmark against other trusts, acute hospital trusts?
Yes, so we're not at the top and we're not at the bottom. We're roughly in the middle in terms of acute trusts at the moment. In terms of stress against the region, again, against regional, I don't have national data, I have regional data, and again we're in sort of in the middle of the pack. Stress percentage is between 28 and 37% of most absence. We have reduced our long-term absence over the past few months, but what we are not yet affecting change on is short-term absence. And short-term absence these days you can record as being off on stress from day one.
Okay, no, thanks for that. And what support mechanisms do we have both for managers, line managers and employees to support them through stress and to help to alleviate some of the impacts? I mean, it's a very stressful job a lot of the time on the front line, but what do we have to support staff?
So we do have a SharePoint that we've put together that has a myriad of different resources, both from support from the community, our WorkWell partners, our employee assistance programme, but there's also a myriad of other things in terms of supporting staff from a financial perspective as well. Because stress obviously can be generated from a work-related, but also from a home-related situation, and sometimes the two things come together as well. We have our occupational health team, which obviously we're looking for additional resource. One of the additional resources that we are asking to put into place is a mental health nurse out of the two posts that we put the business case together for. That's what we would like to invest some more money into.
That looks like a sensible investment, looking at the increase in numbers. Thank you. Thanks, Alison.
Okay. Anything else for? Yes, we've got some more. Becky.
Just really for any staff that are watching this board meeting, that the Oliver McGowan training is probably one of the most impactful mandatory training you'll ever do. I'm fairly hardened these days, but it brought me to tears watching it. And, I think it's a really, I would advise any staff that haven't done it to go ahead and undertake that training, because it is so very important.
Thanks, Becky. Of course, we've done it as a board. Alison?
Yeah, as I say, we echoing what David said, we've done it as a board, and I would hear what you say in terms of emotionally it has that impact. We've got the tier 1 and the tier 2 training. We have our own lived experience trainers. We did consider, Adam, a suggestion on trying to focus on that, but their availability and the need to have regular breaks meant that we couldn't focus on it. We need to continue providing it in the way that we've agreed the contract with themselves. However, in conversation with the divisions, we took a paper which was about accelerating as we're not going live with eCare, about trying to concentrate on appraisals and statutory mandatory training, which includes Oliver McGowan, and to try and use this opportunity now to try and catch up.
Thank you. Are there any other comments? Don't think so. So we do need to receive and note that report for the meeting. But maybe, Lindsay, we should just also note the comments that have been made about the Oliver McGowan training, but its importance. Thank you very much. Takes us on to item 13, the Audit and Risk Assurance Committee. Adam.
Thank you. This is our assurance report on 2 Audit and Risk Assurance Committee meetings we held in June. We had an extraordinary one and a normal one, for want of a better term. And to take everyone to the extraordinary one first, I just need to point out, I've only just noticed a typo in our papers on page 241 of 614. The Extraordinary Audit and Risk Assurance Committee, as we all know, was focused on independent assessment of our financial health for 25-26 financial year. So there's a couple of references to 24-25 financial year on page 241. If we can just correct those, please, Lindsay. So we had consideration of the internal audit assessment of our performance for 25-26, which was a satisfactory opinion. We had our external auditors assessment of 25-26 from a financial perspective, and they concluded with our annual report was appropriate, and our financial statements, our financial accounts were deemed to be unqualified. So that's basically saying that we were presenting a true and fair view in terms of our financial position in all of our financial information for last financial year, which is an important independent assessment. So we were delighted to get that. And I'm pleased to report that we got an improved assessment of our value for money performance from our external auditors as well. And we need to celebrate that, picking up Adrian's point from earlier. And I need to thank an awful lot of people from across the organisation that worked really hard on all of the important documents that were produced for that Extraordinary Audit and Risk Assurance Committee. Immediately we finished the Extraordinary Audit and Risk Assurance Committee, we went straight into a board meeting to effectively consider the same things and for the board to approve those, which the board did in every case. Which is good, and they come to a public meeting later in the year. And we also had a normal audit committee, and the one thing to highlight to board colleagues from that is on page 238 in our pack. As usual, we had a report on the corporate risk register. We've got the same report in our pack later on in section C. We flagged that we felt we could improve how assurance was being given around the corporate risk register. Something that we will continue to look at as an Audit and Risk Assurance Committee, not asking the board to do anything today. Richard Cramer and I have a follow-up meeting with some of Bernie and some of her team to look at how we can improve assurance around the corporate risk register. And I will stop there, Chair. Thank you.
Very much, Adam. As I mentioned at the extraordinary board meeting, this year we'll be holding our annual public meeting in person. So planning is underway for that in September. What's our questions for Adam, please? I think we just do need to note as a board with concern the attention you're drawing to the level of extreme risks. I'm sure we've all noticed that the overall level of risk exposure of the trust is gradually increasing over time, pretty much across the board. Although we do whatever we can to mitigate it, we need to recognise as a board that we're carrying a lot of risk and therefore a lot of accountability. Subject to that, are we happy to note the report of the committee? Thank you very much. So we now go on to the board assurance framework. Lindsay.
Thank you. So the Board Assurance Framework provides our latest position and highlights amendments that have been made following the relevant committees and review with the executive leads. The BAF remains our key tool for overseeing the principal risks to delivery of the Trust strategic objectives, and it highlights continuing work to align the framework with the refreshed Trust strategy and our review of a risk appetite which undertook in June, and with the aim of presenting a refreshed and final risk appetite statements for board in August, ahead of going to Audit and Risk Assurance Committee later in August. Matters of particular interest relate to under the safe and high quality care element. The report strengthens the narrative on urgent emergency care, including flow and corridor care, noting that corridor care remains a significant concern and further work is being further assurance is being sought through Quality Assurance Committee. With regards to workforce, the report reflects our progress on our culture transformation, and the report also recommends the closure of the previous culture transformation task force action, as this is now concluded because we actually do have a culture group in place. The report also draws attention to the impact of the pause of the eCare Go Live, but the board will be aware we are later today scheduled to discuss that revised Go Live date. In relation to finance and performance, the key areas to highlight are around the development of the elective recovery trajectory to support achievement of 81% of RCT, as well as strengthening our gaps in assurance around estates for relating to severe weather, resilience, etc. Overall, the paper provides commentary on our common themes across the BAF, and they remain consistent with previous months. Thank you, Chair.
Thank you very much, Lindsay. Questions for Lindsay? So thank you for all the work that's gone into that, Lindsay. And obviously we need to note the report and new gaps in assurance and mitigating actions. And we also need to approve formally the closure of Action 7C around the Culture Task Force since the work has concluded. Not the work of the task force, but the culture group is taking it forward. Okay, Thank you very much.
Thank you.
Then we come to item 14, Remuneration and Appointments Committee, which is chaired by Isabel Down, wearing her Senior Independent Director hat. Isabel?
Thank you, Chair. I do like the different hats. Yes, this would be an even quicker report than usual. Because you'll see in the paperwork that there's actually no content. So I think all I would say is that this committee presents a summary of issues that the Remuneration Committee have to consider as part of its responsibilities. One of the key ones being the recruitment of our Chief Executive. So I think our June meeting and other meetings actually have been considering the Chief Executive arrangements following the departure of our previous Chief Executive, and the support for the acting Chief Executive arrangements in the form of Kim. So I think there was some work to do around that, and we've met a few times around that. The other two areas away from recruitment are that we have a responsibility to receive annual appraisal and objectives, both for the Chief Executive, but also for all the executive directors. So this committee has received and discussed and supported the arrangements that have been put in place for our exec team in terms of their annual appraisal and the objectives set for the coming year. So I think I will stop at that point. Thank you, Chair.
Thanks very much, Isabel. Obviously, we can't talk about individuals in public, but are there any comments or questions for Isabel? So thank you for that report, Isabel, which we'll duly note. Now, if we could go on to item 15, the Integrated Performance Report. Joe, just for you to know, the way we tend to deal with this is that much of the most important aspects, I mean, it's all important, but the things we really need to focus on as a result of increasing risk, we've already dealt with corridor care and so on. So we do it by exception reporting. I think it's very good to have the new format. It's very accessible, and I like the way it's linked to the accountabilities of committees and divisions, because the 4 new divisions are going to be at the heart of improving our performance. But in that context, is there anything you wanted to say?
No, thank you, Chair. It was just to say, yes, we've had good feedback from the Finance Performance Committee and Quality Assurance Committee on the new format. And exactly that, the divisional chairs and the divisional directors that have got that direct line to board, because they put their information straight into the slides. They've provided an update there, so that's welcomed. It also includes now a snapshot of the oversight framework, which I think people have said that that's very useful to have. The only thing that I really wanted to pick up, because we have talked about quite a lot of the key issues, I would say, that are highlighted in the report, is the elective recovery. So I just wanted to make sure that everybody was assured that at the moment, whilst we have some variation against plan in certain areas, we have got a twice weekly delivery assurance meetings now in place with the divisions. We have the clinical vision for planned care programme that has met now for the last 2 months, and we have a really solid set of plans, and we've met with the regional team to go through those plans, and they are feeling more assured that we are going to be able to recover some of the position. Lots of work happening there, and all services now, whether they are meeting their trajectories or not, have improvement plans in place. So some plans have been signed off and some have still got amount of work to be completed, but everything will be signed up and finished by the 21st of July. There is, as I said, there's key immediate actions that we have been taking across the IPR, and I just wanted to pull out a couple of ones. The implementation of daily executive review from Robin on discharge performance, corridor care and ambulance handovers, as well as the elective care trajectories, and talking to the divisions about waiting lists. As you'll see, our waiting list is a concern at the moment, and what with the divisions and the business information team who are leading on the outpatient transformation, we have a strong set of actions to bring the waiting list in line or reduce it for next month. So if that happens, if those plans come off, we should see a reduction, although it is still challenging. The increase in theatre productivity in the Start Well programme in theatres has commenced and is showing small gains there. So that's continuing with support from Gary Matthews, the AMD for planned care and theatres. He's supporting us in that. And the stroke programme, as we talked about the stroke, the plans around that capacity and demand piece of work, but also working with the internal team about flow through the unit. So not a lot else that I wanted to pull out that we haven't already talked about, but just to say they were the key focus areas.
Thank you. It's very clear. So I think we need to get into a routine of just checking with committee chairs to see if there's anything they wanted to open up for discussion at board. We can't do it with people and culture because they haven't yet considered it, but I'll just get into the habit of checking with all three of the, other than the audit committee, the three main committees, just to see if there are any issues the chairs need to escalate or expose to the board. Adrian?
I've asked for some further information to come back to the next Finance and Performance Committee, so I'll be addressing that through that forum, if that's okay, which will then come back to board.
We get into a nice rhythm then.
Yeah.
But whatever about the IPR should stop at the relevant committees, that's fine. But every member of the board, should be able to talk about the IPR as well. And I just wanted to note that the full report, warts and all, is placed before the board and the public. So it's all. I'm glad that the report is very open about the challenges we face. Doesn't pull any punches. That's good. Isabel, anything from Quack?
Well, like Adrian, I've requested from Robin some additional information, which I think will help the Quality Committee, but also working across with the Finance and Performance Committee around urgent and emergency care. So we're doing a bit of a double act across both committees on that. But just also to say, really welcome this new format. I think it's going to prove to be very helpful, and I really like your idea of just checking in with the committees, because I think it will save us time in the discussion and make us focus on where we need to be. Thank you.
And that's not in any sense repeating the work of committees, but just making sure we've got maximum transparency. We think that's good governance.
Yeah, I think as the day's gone on and you look at the work the committees are doing, we had our first meeting yesterday, and without creating more work, I do think if we're going to proactively and the national operating framework, it isn't about hitting the metrics, but actually we have to be really clear that not meeting them and having a financial override is what we should be focused on. And I notice it's going in different formats throughout the subcommittees, but with meeting with the relevant execs yesterday, I do think we need to look transparently at that triangulation report and what does a dedicated improvement plan look like. We do know the longer term metrics, such as a staff survey. We keep saying, yes, we're stuck with this one until the new one, but actually without taking some of the cultural measures, actually we're going to be stuck with next year's. So actually, how do we proactively get a hold of that? Are we all then looking at the same metrics with the same transparency, doing the right triangulation, and then one report should be able to come through and then escalate it at a board level? So we will look at what that looks like in the next week. I'm just conscious it can't be longer. It can't go on too long, otherwise we'll be in the next quarter. And we've got to be really honest, quarter one is baked now and done. How are we proactively going to look at making sure we remain as autonomous as we can, not get into financial override, but absolutely make this better for our communities and our staff by taking the right meaningful actions. So I will look at that, and then we need to consider how we do that and take it forward.
Okay, thank you, Kim. Well, I guess that's executive coordination first, and then board oversight.
Yeah, absolutely. And then what goes through committees without putting everyone in override or trying to bring a whole generation of or family of reports together, and we get lost in the data. And that is our board, you know, it's recognised in both of the national reports coming through that boards get overloaded with data, and we might miss the true meaning that's running up behind it.
I can't remember if it was Ockenden or Amos or both, but one of them said that I think it must have been the Nottingham one. Ockenden said that the board relied too much on committees.
Absolutely.
On the other hand, of course, we do need to trust our committees, so there's a balance to be struck. So while it's right to have an integrated performance report focused on divisions and committees as appropriate, there is a duty on the whole executive and the whole board to make sure it's all joined up and triangulated.
Yeah, absolutely.
So could we reflect that, Lindsay, and maybe as company secretary, you might want to give that some thought.
We will take an action, Chair, as well, that we will consider that and put that proposal to the board.
Otherwise, we can't remain curious.
But subject to that important caveat from Kim, I think we're saying we like this new format. But the risk is that we can't see the wood for the trees, so we just need to resolve that offline. And Richard, clearly Quack and FPC have already done this, but PCC will take a look, and you can provide a similar report at a future board.
Yeah, thank you, Chair.
Thank you. So could we note that with those additional points? Bernie, did you want to speak?
I was going to put it in touch that, but in light of the Amos and Ockenden reports and the 10-point plan that's come out, we are expecting some national guidance to land today. They told us it was 48 hours for triage, which is of concern in terms of urgent and emergency care for maternity services. So we will need to think about some maternity metrics in the integrated performance report, and I will work with Robin on those, but it's just to give that forward flag to the board in relation to that matter.
Thank you, Benny. So now I think we turn ourselves into the corporate trustee as opposed to the trust board, and take the report from the Charitable Funds Committee Richard.
Yeah, so first and foremost, the committee is assured that the charitable funds are well governed with strong oversight of fundraising, investments and expenditure. We talked about delivery risks, particularly state-related delays, which are being actively managed and looked at. The underlying year-on-year financial performance is broadly stable and there's no matters requiring escalation to the board. I think a recurring theme was to look at the difference that charitable funding makes, whether we're talking through our beneficiary stories or our communications to patients or staff or our 3-year strategy. And we welcome the beneficiary story regarding the kitten scanner, which helps children understand MRI procedures. And we really felt that was such a brilliant, tangible benefit that could be promoted much more widely across the trust and outside through primary care, and it provides just better care for children and families. We also talked about the Women's and Children's Programme and how that might be one of the most significant future fundraising opportunities for the charity, and a commitment to look at that in the future. I've been asked by the charitable funds to present with some gusto and razzmatazz, Chair, the lottery. I did want to use the glitter gun to do that, but unfortunately, just to board should note, I did approach corporate governance for the aforementioned glitter gun, which is located in a desk third drawer down in the corporate governance department, but under a lock key. I wasn't allowed to use it because of concern of the, I think the canyon of confetti and the red and white stripes might land in the chair and chief executive's hair. So that was put to one side. I wasn't due to present today, actually. I tapped Adrian up for one of his historic celebrity contacts. And unfortunately, Harry, not Prince, the Harry is unfortunate to take on other business and won't be back with us to July. So I am forced to present about the lottery. So here goes. Thank you very much indeed. Dad jokes put aside. So I'm really pleased. Oh my God, what has happened? What committee am I in? I'm really pleased to announce the launch of the charity lottery. It's really, really important. It's open to all colleagues and members of the public. It really represents an opportunity to raise additional income, engage new audiences, and actually increase brand visibility, something direct that people can see and feel, and a chance to win cash prizes that will actually help fund projects that enhance patient care, support wellbeing, and improve the hospital environment. So today is very much about building awareness. It's about encouraging people to, when they visit the site, to buy a lottery ticket, and we really value the support from colleagues and board members to help promote the lottery and spread the word. That's your razzmatazz. Thank you very much indeed.
Thanks, Richard. Can we all have some of what you're smoking?
Yeah, I think that was not.
Yes, Chair. I just wanted to say that this committee is a fantastic committee that I'm privileged to sit on. We see the beneficiary stories and we get to see the difference that charitable funds make to the services that we give to our public. And I would say, anybody have a look at the kitty scanner video. It's really, really good. The second point, that, and obviously being a public meeting, I would invite the public to look at some of the charitable funds beneficiary stories. The other thing that I wanted to raise was that Richard and myself visited the family accommodation project last Friday, and again, it's absolutely excellent. It's going to be a really good asset to have, and I couldn't believe how close it is to the hospital. So well done to everybody involved. Thank you.
Thank you, Adrian. And thank you for raising that. Are there any other comments or questions for Richard? I guess it's either me or you who has to pour a bit of cold water by clearly we want to promote the lottery, but I suppose we should make it clear that
Unfortunately not, no. But all staff watching can buy a ticket.
members of the public.
Yes, and members of the public, definitely.
So, I think we're entitled legally to wish the lottery every success because it raises funds for our patients and our staff and for our trust. But for obvious reasons, we can't participate, even if we won and gave the money back. Thank you for that. Can we note that, Richard? And as I say, wish you every success. And I'm pleased to see the emphasis on fundraising for major capital projects like the Women and Children's Hospital, because I'm sure there'll be trusts and foundations and high net worth individuals who would want to be associated with naming opportunities, equipment opportunities and other opportunities. So thank you for that. And we go on to section C. Nobody, I think, Lindsay, has asked for any items to be put from section C into section B. So all the items from 17 down to 23 inclusive just lie on the table, although of course we've all read them. And we take the necessary actions from them, which takes us to section B, other matters. And the first one is summary consideration of risk and matters for celebration. Lindsay.
So if I cover risk first, so we've talked a lot at the committee today, at the meeting today, sorry, with regard to matters that are picked up through our committees and are currently reflected on our board assurance framework. But it's helpful just to go over those again. So particularly UEC remains a challenge for us when we have a risk score, corporate risk score of 25, so which is our highest risk score. However, we appreciate that this is being managed through Quality Assurance Committee, and particularly further assurances are being sought with regards to corridor care. So I think we'll update the board assurance framework following that discussion. Obviously, the staff survey and the ability to move at pace, and we recognise that today we've been assured around resources being put in place, and People and Culture Committee have oversight. We've highlighted again, obviously, fracture remains a challenge, but Quality Assurance Committee have oversight for that. Culture, particularly, and we discussed a lot around inclusivity, racism, discrimination, and ensuring the visibility of these and how we can capture that within our corporate risk register and our board assurance framework, I think is important. Other areas of risk around industrial action, obviously we've mitigated that risk with the pay deal, and I think other areas to highlight again, sickness absence, we have captured that, but I think following the deep dive at People and Culture Committee, it would be an opportunity to review that. Areas for celebration, we talked again about compliments today and how we can, we do receive a lot of compliments, but we need to think about how we record that, but we do receive a lot of compliments. We have had good financial discipline over the last 12 months, and it was positive to see the medium-term financial plan in our papers today, so that's an excellent piece of work. We should also celebrate the positive audit assessment of our accounts and the value for money work, and obviously that'll be presented to our annual public meeting. I think probably the best things for us to celebrate today is the trust lottery, and it is the fact that we do invest in excellent opportunities and for our patients and our staff. I think it's a real thing to celebrate is how we use our charitable funds.
Yep, that's great. Perhaps the kitten scanner as well.
Yeah, thank you.
Any other matters to celebrate or risks raised? Ian and then Ella. Ian.
Yes, I think on risk, we also touched on the increasing capital risk, which we've flagged through the papers, but also probably that element I updated on verbally around the regional risk measurement that they'll be undertaking on a monthly basis. So as part of our BAF review, Lindsay and I will review that and update that accordingly, Chair.
Ella?
Sorry if I missed it. It's an Ulster Surgical Hub accreditation as a celebratory point.
Do you want to celebrate?
No, yeah, otherwise we'll lose the lottery celebration.
Ready?
The bladder-related improvements in maternity resulting in less litigation, I think, is something to celebrate.
Speaking of bladders, we are moving towards the end. Alison?
I can top that. Really. I was just going to recognise the launch of the high potential scheme across the system, and it's great that we've got RCHT colleagues on it.
Sure.
Could I just mention, I think we touched on it, but during the heat wave, across all our sites, how our staff managed in that heat and how they kept patients as cool and safe as possible. So yeah, tremendous work.
Collaborative working with SWAST and
Yeah.
partners. I think.
Yeah.
I don't think we can overlook Kim's executive decision to order 6,000 lollies.
Yes, yes.
I know in maternity we're greatly welcomed, but
Yeah.
across the trust as well. It just shows, I know it's a small thing, but it shows what you're trying to do.
Remember?
And was well received, which is lovely. Except not to finance.
A local supplier, no doubt.
And I'm teasing about finance. They took out their purse with a smile.
Thank you. So thank you for doing that on the hoof, Lindsay. That was very impressive. Thank you. And thank you to board members for contributions. It's nice to think towards the end of the meeting that despite the pressures, there is quite a lot to celebrate, actually. Item 26 is questions from the public. Lindsay.
I've had 2 questions from Jane Bennell, and I'll read them out and then I'll go to Joe Floyd. So with regards to discharge, she said, what reablement and liaison with services outside RCHT will be provided to patients on the discharge wards to prevent further deconditioning risks and risk of repeated admissions and facilitate their timely discharge? She also has asked around inpatient corridor care and how many patients remain in spaces not designed for a bed. She understands that there was 46 earlier this year, and has that number increased or decreased? And does staffing increase pro rata when a ward is required to be put up? Does staffing increase pro rata when a ward is required to put up extra beds? Thank you, Jo.
Thank you. So yes, the discharge wards and the discharge readiness unit that we're planning to work up based on a Chelsea and Westminster model. We already have adult social care and Cornwall Foundation Trust staff services on site in the form of the team called Chaos and Steps. They already come in and do in-reach to patients. The plan to have the discharge readiness unit is really around that designated unit will provide further effectiveness in the coordination and communication. So where patients are in that unit, alongside the RCHT therapists, the discharge coordinators and the outside services, it gives them a real base to be able to flow a lot quicker and the communication works better. I went up there myself and saw that in action, and it was led by the nurse in charge, and it's a very good efficient model rather than staff roaming around the hospital looking for patients that are medically optimized but need some sort of onward care or reablement. So yes, there will be support services in reaching, and that may expand yet under discussions that we're having with community services. The inpatient corridor care, we can flex up to 47 spaces. That's a new metric that's in the integrated performance report now that will be reported monthly. We can flex up to 47. It doesn't necessarily that we use all 47 all of the time. In peak surges, as we've seen in May, twice we've had to flex right up to the amount of spaces that we've used. And of course, the staff safety model is managed twice a day. So we review day shift and night shift to make sure that all areas, all wards, whether it's escalation space or not, or corridor care space or normal wards, are all working at a safe model level. So that is flexed as well daily. So yes, I can give you assurance there. Okay.
No further questions, Chair. Thank you.
So could I just thank Jane for usual probing and intelligent questions? And I hope that was a satisfactory answer for you, Jane. I can't see you, I'm afraid, but I hope you can hear me. So if we can move on then from questions from the public to meeting effectiveness evaluation. Are there any comments on what worked well, what could have been better? And how we've contributed to patient safety and communications, etc.
Yeah, really welcomed Becky's input around health inequalities, because I think it's something we've talked about many a time on our reflection actually on effectiveness of meeting, is how do we weave that in more. So it's really great you did that. I think we caught up in the corridor, didn't we? We need to think about with Robin, how do we really embed it in our oversight and assurance framework, as we go forward, so that it's not something that stands alone.
I'd just like to thank all the executive directors for helping us pace the meeting by keeping their introduction short, which has meant that we're going to finish, pretty much on time, and we haven't had to rush things towards the end. Because I felt once or twice, Ian, we've had to rush you a bit, and today I think you've had all the time you needed. Mary, did you?
Well, I was going to mention that I thought that the real focus that we'd had on the succinct summaries actually went really well. So I was going to say as well. And I know it's been said in other committees, but for people who are perhaps not so financially adept as others, the new format of the papers is way better. It's them and much easier. Yeah.
Happy board? That's the right answer. So if we can move on then to the date of the next meeting. Our next public board is the 3rd of September. We're going to have a special meeting to look at Lord Mann's report and the full inquiry before the end of July. I'm sorry about that, but I hope we can find an hour before the end of July to do that. So I think I can close this meeting. Just to say to those online, I did wonder whether we could start the private board a bit earlier, but we do have somebody coming on a time basis from the new hospital programme. So it might be better to keep the start for 1:30. Or do you think we could start earlier?
Probably start a little bit earlier because we can always take another item ahead of the NHP colleagues joining us. So maybe 1:15.
So could I suggest, if online colleagues are happy, we still have a half an hour break, but that we start at 1:15 rather than 1:30? It should just let people who've got to travel later get away earlier. So let's come back then at 1:15. And thank you very much for your attendance. I'll close the meeting. Thank you.